We're now going to proceed with the the experts from the Baptist Health Miami Cancer Institute. The moderator for this module is Dr. Manmeet Ahluwalia. He's our Chief Scientific Officer, Deputy Director, and Chief of Medical Oncology, and the Fernandez Family Endowed Chair in Cancer Research. Dr. Ahluwalia will be joined by Dr. John Diaz, Chief of Gynecologic Oncology. By the way, I believe he's still the Chief of Robotic Surgery also. Chief of Robotic Surgery for the whole system of Baptist Health. Dr. Minesh Mehta, Deputy Director and Chief of Radiation Oncology, and the John and Mary Lou Dasberg Endowed Chair in Radiation Oncology. Dr. Murugan Manoharan, Chief of Urologic Oncologic Surgery, and the Abbey Family Endowed Chair of Urologic Oncology. Dr. Gunther Kona, Deputy Director and Chief of Bone and Marrow Transplant Hematologic Oncology and Benign Hematology. And Dr. Jane Mendez, Chief of Breast Surgery. Dr. Mendez will be with us shortly. And with that, I will give the microphone to Dr. Ahluwalia. Thank you so much, doctors.
Hi, good afternoon, everyone, and welcome. I could not be more thrilled to join on stage with 5 of my esteemed colleagues who are going to talk to you about some of the latest advances in fields that they not only see patients in here, but some of the research they're driving here in South Florida, but throughout the world. And I'm the designated first speaker. So I'm Manmeet Ahluwalia, as introduced. And I'm being tasked today to talk about precision medicine in neuro-oncology, shaping the future of the brain tumor treatment. So I'm going to talk about brain metastases since it's 10 times more common than the gliomas that we see. And I know you in the morning probably had a treat listening to Dr. Evan Bender, who talked to you about the surgery of brain metastases. So brain metastases is a common clinical problem we see in the United States every year. Up to 200 to 250,000 patients will be diagnosed with brain metastases. So if it was a cancer by itself, it probably would be one of the most common cancer. Of the cancers that actually go to the brain, the most common cancer that goes to the brain is lung cancer, which is 50% of the cases. The second one is breast cancer, and third one is melanoma. So these are some of the tumors that I'll talk about today. But more important thing to keep in mind is until a decade back or so, the outcomes of patients with brain metastases was pretty dismal. These patients only lived 9 to 12 months. And most of the care was given by my colleagues in neurosurgery like Dr. Bender or Dr. Minesh Mehta in radiation oncology. But I will showcase to you how some of the advances in novel therapies with targeted therapies and immunotherapies are really transforming the medical treatments of this thing. So first of all, I want to start off with lung cancer, which is really the most common cancer that goes to the brain, but more importantly, is the poster child of genomic drug development in cancer in general. So 20 years back, when I was in training, we thought all lung cancers were same, or lung cancer was non-small cell lung cancer or small cell lung cancer. But now we do know that based on genomic profiling, that the non-small cell lung cancer, that's the one I'm going to talk mostly about today, is 30 different varieties. And as a result, you will have to test for all these tumors, and you will see some of the common mutations listed here. And the ones which are common in our area is EGFR, for example, which is around 10 to 15% in the Caucasian population, but 40 to 50% in the Hispanic patient population. So we see a ton of these patients here. And this just gives you a snapshot of how genomic profiling and then targeted therapy to treat these patients have really changed outcomes. So here you'll see these 3 types, which are wild type or KRAS, where there has not been much change, but still the outcomes are around 12 months. But then you have the EGFR, which is very common in Hispanic patients, for example. The outcomes are 2 years. And then you have the ALK type, where before genomic testing was available, or rather before targeted therapy was available, these patients only lived 6 months. And now an average outcome of these patients with brain metastases is 5 years. And I'll show you a couple of slides to that. So this is just, again, too many drugs. I don't want you to memorize or try to read all of them, but crizotinib, seratinib, alectinib, brigatinib, these are basically generations of drugs which actually showcase how drug development has happened. So crizotinib was the first generation drug, and it had limited entry into the brain, so limited blood-brain barrier penetration. And you see the response rate is 20 to 30%. So just put it in perspective, when we gave chemotherapy to our patients like 20 years back, the response rate was 5%. That means 1 out of 20 chances you gave chemotherapy to your patients and the tumor would shrink. Because what does a cancer patient want? They want the cancer to go away or at least shrink. But these new drugs, when they came up initially, had response rates of 20 to 30%. So that means they were 4 to 6 times better. But the newer generation drugs, as you can see, have response rates 50 to 70%. So they're not only keeping the tumor stable, they're actually shrinking the tumor. And so I just want to showcase that with this drug, which has really become the poster child of targeted therapy in brain metastases, and that's this drug called lorlatinib. And here you can see the response rates are 82%. But even more important is not only the response rate, but also you can see the progression in the brain. So the first drug that I talked about was crizotinib, response rate 20 to 30%, same thing seen in the study. But at 12 months, it fails in 30 to 40% of patients. But when you look at lorlatinib, it only fails in 3% of patients in the brain. And brain is one of the most difficult places in the body to treat any solid cancer. So this was a study presented at ASCO, and this is the 5-year outcomes of the study called CROWN. And you can see the blue curve. Even 5 years out, these patients are not failing in the brain if they don't have a brain metastases. But the lower curve is those patients who have brain metastases. So imagine 20 years back, these patients were living 6 months. And now if these patients get this drug, there's an over 80% chance that their tumor is not even progressing at 5 years. This is the transformative change. Genomic testing married with targeted drug therapy has the potential. Obviously, this is probably one of the best examples, and that's why I'm giving it to you. But this is what is now becoming the holy grail of genomic testing and treatment. So at Miami Cancer Institute, we actually use Caris Life Sciences in solid tumors, which is one of the most commonly used tests, but also very robust tests. They look at the whole exome and transcriptome. That means we look at the entire DNA and the RNA. And just giving you another example of this drug, the results came out in the last few years. It's a drug called sulpercatinib. And the reason I'm using this is because it's RET fusion. I'm giving you the story in lung cancer, but this is true for RET fusion, which can occur in other tumors like even thyroid cancer. And here again, you can see 80% response rate. All these bars going down means the tumors is shrinking. So you can see almost in every single patient, the tumor shrank. And in several cases, which are seen in the red bar graphs, is complete response. That means the tumor shrank or disappeared completely. So really exciting stuff for our patients as we see them. Next, you heard this morning from Dr. Justin Sporer about some of the groundbreaking work he and his colleagues are doing here with high-frequency ultrasound for tremor. I'm sure he showed you a beautiful video of a patient with a transformative change from tremors while the same day. Unbelievable stuff. It was on 60 Minutes, New York Times. We are driving the same work here in brain tumors because when you use the low-frequency ultrasound, you can actually non-invasively disrupt the blood-brain barrier. And one of the challenges in the brain is that the drugs don't reach the brain, right? Because of the blood-brain barrier, the protective lining. So this modality can artificially, non-invasively disrupt the blood-brain barrier for 4 to 8 hours, and then it starts sealing within 24 hours. And we have shown through MRIs that after 24 hours, the blood-brain barrier is totally sealed. So that if a drug goes in, it won't come out unless the flux pumps put them out. But in short, this has really ushered a new era of potential transformative changes that we can make for our patients in brain tumors. And we have, along with our colleagues in University of Toronto, shown that to be true with a large molecule with trastuzumab, a drug commonly used for HER2-positive breast cancer patients, with the radio labeling tracking. But one of the other beauties of this thing is when you do this, you can actually also augment the immune response. You can actually do immune priming by improving the tumor infiltrating cytotoxic lymphocytes. And I'm sure Dr. Kuna will talk about some of the groundbreaking work he's been doing, looking at T cells and enhancing immunotherapy. So this is a global trial, actually, looking at lung cancer brain metastases along with pembrolizumab, along with Alemta and carboplatinum, and using the blood-brain barrier disruption system. And actually, I serve as the global PI of this trial. And Dr. McDermott, one of my colleagues, is also driving this study from a neurosurgery standpoint. And we are seeing very intriguing results. And hopefully by next year, I'll be able to showcase to you some beautiful pictures of patients who are getting really nice responses. We are looking at this thing again in trying to increase the yield of cell-free DNA in the blood. So as you know, liquid biopsies have really transformed outcomes in, say, lung cancer. But in brain tumors, the problem is when we sample the blood for liquid biopsy, not enough DNA is released, again, because of the blood-brain barrier. So this is actually an FDA approval study where we are hoping that using this modality, we'll be able to double the yield of cell-free DNA. And we have enrolled around 44 of the 50 patients that need to be enrolled. But you can see marquee institutions which are partnering with us in this trial. And we are again leading this trial out of MCI. Moving on to breast cancer, I know Dr. Mendez will talk about all the work that she's doing in breast cancer surgery. But when breast cancer goes to the brain, again, the subtyping of your tumor matters. So patients who tend to have hormone-positive disease or HER2-positive disease tend to do better. And the ones which are in the gray, the worst outcomes are patients who have triple-negative disease, which tends to be very aggressive disease. So tucatinib is a novel therapy that was FDA approved, actually was the first drug that was FDA approved for brain metastases on the label. So it's a combination of trastuzumab, tucatinib, and capecitabine. Trastuzumab was the drug I had referenced before when I talked about some of the work we have done with the focused ultrasound. And here you can see in the blue curves, much better outcomes, in the blue curves, much better outcomes compared to the red curves, which is placebo. And you can see hazard ratios of 0.32, which is extremely impressive. So we are leading this trial out of, again, Miami Cancer Institute, combining that with radiosurgery. And Dr. Mehta will talk about some of the work that he and his colleagues are doing in radiation oncology. I would say actually right now, we're probably one of the best brain tumor programs in the country with some of the people we have working in neurosurgery, radiation oncology, medical oncology, as well as neuro-oncology. So this is one of the trials we are leading nationally and internationally. Actually, we got 3 different grants to lead this study called Tutor Trial. And this really established us to be the coordinating center of the International Radiosurgery Research Foundation of the world. And you can see it's 40 cancer centers around the world. And you can see some of the top names in the United States, including Cleveland Clinic, Mayo Clinic, NYU, Yale, UCSF, and the others. So we will coordinate the brain metastases trials for this foundation. And we got a foundation grant from International Radiosurgery. We got a grant from Pfizer, and we got a grant from V Foundation and Swim Across America to fund this study. Next, moving on, as you know, in the last few years, there has been a lot of excitement about antibody drug conjugates. And what those are basically Trojan horses, because previously we used to design these drugs which would go and attach to the receptor and then, or a protein, and then would act. But then what we found out is we can get the drug to get into the cancer cell using the same receptor. And this was a trial of TDXD, which is really a drug that has transformed outcomes of patients with HER2 breast cancer, either positive type or even low type. To just give an example, when they presented this study at ASCO, there actually was a standing ovation in the plenary session. ASCO is, as you know, the Super Bowl of oncology, 50,000 people, attendees. And it has happened like 2 times in 20 years. And this was this study was presented with breast cancer because it not only beat the previous drug, it beat it by 4 times. So typically when we get drugs approved in cancer, we get a benefit of like 3 months. This drug changed the benefit from like 7 months to 28 months. It was like 4 times better, which is highly impressive. So this was the trial they did in the brain. And as you can see, again, 70% response rates. Actually, we were quite baffled by this because we didn't expect a large molecule to work in the brain. But we are seeing the really good responses in a small study led out of Vienna with our good friend Matthias Prusser and his group. But at the same time, as I mentioned, a lot of times we use radiosurgery, which has been the traditional way to treat these patients. So when some of the early work was done with these antibody drug conjugates, along with radiation, there's a high degree of radiation necrosis. And so we got $1 million grant to actually lead this trial, again, out of Miami Cancer Institute, and we are coordinating with the 4 cancer programs in the state of Florida to look if it is safe to give this drug along with radiosurgery in prospective manner. Then just talking about some of the other groundbreaking work that is being done out of Miami Cancer Institute. This is a RAGE inhibitor called ezraligon, and it basically RAGE inhibition can act as a neuroprotectant. So a lot of times when we give radiation to the brain, although we've become very sophisticated, and Dr. Mehta will talk about proton therapy or radiosurgery, which we can use to mitigate some of the neurocognitive side effects of radiation, it's still a challenge. So RAGE inhibitor can actually serve as a neuroprotectant, but also can be a sensitizer. And there's preclinical evidence that the combination is really beneficial in brain tumors, triple-negative breast cancer, and pancreatic cancer. So this is work led by my colleague, Rupesh Katocha here. And you can see this patient had 4 brain metastases, and 3 of them actually resolved, and the 4th one shrank. So some really exciting results, which is leading to a new path forward. And you can see several trials which are being led by physicians here at Miami Cancer Institute, Dr. Odia, Dr. Press, and several of us working very closely with the company, including Minash, who's got a great relationship with the company, to design some of those trials here and nationally. So what are some of the future directions and takeaway points from the brain metastases component is that we know that radiosurgery works great, and I'm sure Dr. Mehta will talk about that, but now we have drugs like targeted therapies and immunotherapies which can augment this, because we think the combination strategies are the best for our patients for long-term outcomes. And we know these therapies, targeted therapies and immunotherapies, work very well systemically. And Dr. Diaz will talk about some of these therapies, for example, in gynecological cancers. And we always believe that clinical trials is a way to advance care. So not only are we leading some of these trials locally here, but we are leading several of these trials nationally and internationally. Then I'm going to, in the last 5 minutes, I'm going to talk about just a snapshot of other tumors, because I was asked to talk about all brain tumors. So this is a lot of exciting work that has happened in IDH mutant gliomas, which are around 3,000 to 5,000 low-grade and grade 3 gliomas are diagnosed. And 12% of all gliomas tend to be IDH mutant. And then there's a beautiful mechanistic story of development of an oncoprotein which actually drives the cancer in these patients. And so they then designed a drug called vorasidenib. And this basically, because a lot of these patients are young, sometimes we don't feel the need to treat them, so they may be they may be put under observation. So this trial, which was presented last year at ASCO in a New England Journal of Medicine publication, showcased that this drug works well for these patients compared to placebo. Also, there are a lot of unanswered questions, and several of us are working to answer that unanswered questions. And this trial was actually led by a colleague, Ingo Malinghoff, from Memorial Sloan Kettering. And as you know, we have a Memorial Sloan Kettering alliance. So again, something that we have great access to. Then this is another beautiful mechanistic story of a drug development focused on H3K27 mutant diffuse midline gliomas, because most of the kids who develop these midline gliomas have very poor outcomes when we use the traditional chemotherapies. And this work that was driven by Dr. Mehta, Dr. Ardia, Dr. Hall, several of our colleagues here, a very high level publication in Cancer Discovery showcasing that we are almost doubling survival of our patients when we are using this drug compared to the traditional chemotherapy. Then obviously when you treat patients, you stumble upon interesting findings. So Dr. Rupesh Katocha, another colleague, was treating a patient with thyroid malignancy who happened to have meningioma, and the patient was getting cabozantinib, which is a drug that works against vascular endothelial growth factor receptor. And what he found was that the meningioma of the patient also shrank. So that led to a trial that he and Dr. Audi are leading here, and we are looking at national partners too, looking at this drug development in meningioma. Traditionally, meningioma is a tumor which has been treated either by, again, neurosurgeons or radiation oncologists. And medical therapy has not had a lot of advances, but some of the early results from this trial are extremely exciting, and we hope this may help us find another opportunity for our patients. Send just a story in the next minute or two about something that I have worked on for the last close to 18 years now. which is a vaccine which is targeted against survivin. Survivin is a protein that's expressed in around 90%, 95% patients with glioblastoma. So I worked in the labs of Dr. Robert Fenstermaker and Mike Krzyzewski at Roswell Park, and they basically designed a peptide-based vaccine which would mount a T-cell response as expected, but also intriguingly found an antibody response also occurring. And we ran a phase 2 trial in collaboration with Cleveland Clinic when I was there, along with Dana-Farber, as well as Roswell Park, and which resulted in a JCO publication, showed an improvement in outcomes of our patients by 1 year. Typically, patients with glioblastoma, as you know, have a very dismal outcomes. Sadly, these patients only live 15 to 16 months. And on this trial, what we found out was that average outcomes for around 63 patients that we treated, the outcomes was actually 26 months. But what I will tell you more importantly, as physicians, we have all treated patients. Sometimes these trials tell only part of the story. And I'll share a story of a young patient I saw who had just been married for 4 months when she saw me, and she had glioblastoma. And her parents were just, couldn't accept the fact that their daughter would have the outcome. And she came and saw us, she participated in the trial, and she had 6 years before her tumor even grew. Actually, she was on Good Morning America 2 times to talk about her story. She even had a kid out of surrogacy. So just a beautiful story. So I think that's what we all strive for in cancer. How can we work to give our patients second chances? Because when people are coming to see us at Miami Cancer Institute, they're putting their trust in us to give them a second chance. And I think that's the beauty of being a researcher or a physician scientist, that you can impact outcome of someone that you see, or maybe outcome of someone you never see. And that's the beauty of research. This is now a phase 2 study that we are participating, which will hopefully have an interim analysis soon, and if positive, will go towards an FDA approval story. So today I just gave you a glimpse of what we are doing, and if I would have given you a whole talk, it would have taken an hour and I would have been kicked out. But bottom line is, this is a snapshot of some of the things that we are driving here at Miami Cancer Institute in collaboration with leading cancer centers, not only in the United States, but around the world. And we look forward to further collaboration with you and your patients so that we can serve them in partnership with you guys. So with that, I will pass on the next talk to my dear colleague, Dr. John Diaz, who's the head or chief of our gynecology cancer program here. And he's going to talk to us about transforming gynecological cancer care, uterine transposition, and fertility preservation.
Thank you, Manmeet. Thank you all for joining us in warm South Florida for our international symposium. And thanks to the international group for inviting me to share something pretty novel that we're doing here with uterine transposition and just fertility preservation in women who are battling gynecologic cancers. So this is our team. This is the Division of Gynecologic Oncology for Baptist Health Cancer Care. We have a group of gynecologic oncology surgeons, medical oncologists, radiation oncologists, and we're adding 2 members next year. So we're the largest group of gynecologic oncology in the state of Florida. I'm very proud of the program that we've built here today. And part of what we focused on is innovation. So women who suffer gynecologic cancers are often treated with a hysterectomy or pelvic radiation, which really eliminates the possibility of future fertility. And this may have been reasonable 10, 15 years ago, when in the 1970s, women had their first child at the age of 21. But women are delaying childbearing, right? And so now in 2024, the average age of women in the United States having their first child is 27 years of age. And so, as we all know, more and more we're diagnosing cancers earlier and earlier. And many of these women have not yet started or completed their childbearing. And in fact, 20% of first pregnancies occur in women who are 35 years or over in the United States. Look how that's changed over the last 20 years. And so we had to adapt. Women were the ones that challenged us and said, no, I don't accept a radical hysterectomy and losing my fertility. That's not acceptable to me. And so a radical hysterectomy, for those of you that are not gynecologic oncologists, is where we remove the uterus, remove the cervix, and remove the area around it to make sure that we have an adequate surgical margin. Danielle Dejean in France developed what's called a radical trachelectomy, and we did some of the first radical abdominal trachelectomy. It's the same concept. We're removing that cervix, but leaving the uterus behind for future fertility. When we first kind of came up with this, people said, you're crazy. How could you do this? This is going to impact, and women are going to have worse oncologic outcomes. And so this was the technique. So it kind of presents like a regular hysterectomy, okay? You can see you open up all the spaces. But then what you do here is you now remove the cervix with the cervical cancer that's surrounding parametria, but you leave the uterus behind. And here you can see the blue dye on that cervix, and that's because this is when we also began our sentinel lymph node experience. You then attach the vagina back to the uterus, and these women can then preserve their fertility for future pregnancies. And we put a permustaclage in, and this was done vaginally. And this is what it looks like when it's done. You can see the sutures there. And this is what it looks like about 6 to 8 weeks after the surgery. It looks kind of like a normal cervix, right? And so this was really a novel concept. And we published the first paper looking at oncologic outcomes, comparing women who underwent these fertility-sparing techniques to a traditional hysterectomy. And what we demonstrated was that there were similar oncologic outcomes between these two groups of women. And in fact, when you lose for disease-specific survival, in other words, those women who suffered a recurrence of their cervical cancer, there was no difference between radical trachelectomy or radical hysterectomy. This was a very novel idea. And in fact, this then became part of the NCCN guidelines. This is what we kind of go through to understand standards of care. This is what insurances use a lot of times to determine whether they're going to pay for these treatments. And it was our paper that was quoted in the NCCN guidelines for approval of this novel surgical technique that allowed women to preserve their fertility and also treat their cervical cancer. So this was a lymph node dissection. You can see how nicely we've cleared off all of the lymph nodes. This is a robotic radical trachelectomy you saw before, the open technique. In my right hand are the scissors. And I think we had a little bit of background audio. So here we're going through the round ligament. You can see now we're going to develop the bladder flap. This is just as we would do it for a radical hysterectomy. And so we're going to dissect that bladder away from the uterus. In my left hand is the bipolar energy source. We put a sponge and a stick in the vagina so that we can outline where the vagina ends, where's the cervix. And you really want to get that bladder away because you want a good 2-centimeter margin here. We're going to open up posteriorly to make that recto-vaginal space. Again, you want to make sure you get adequate margins for this dissection, okay? So here we're making our anterior colpotomy. We're incising into the vagina, all right? Now we've released the cervix completely from the vagina. The uterus is still attached to its blood supply. We're now going to amputate the cervix with the surrounding parametria. And this is where the cancer is, and this is where it's going to be sent for pathology. And you can see once this is removed, what it looks like. So there's the uterus still attached. And here's the radical trachelectomy specimen. You can see there the cervical cancer. You can see the vaginal margin, all right? That's the parametria. That's that margin you saw before. Excuse me. So we're going to take that last section there, send that for a frozen section to make sure we have an adequate margin. This is a Foley catheter insert into the uterus just to help to avoid any kind of stenosis. This is a proline suture we're going to use for a cerclage. There is an increased risk of a preterm delivery. When it was first described by Dr. Dejean, when we modified a technique, we left about 10 millimeters of cervix behind to greatly decrease the risk of a preterm delivery. These women obviously are going to need a cesarean section, so that cerclage is going to be there throughout their pregnancies. You want to be careful because there's still blood supply running there. Those are the cardinal ligaments. We have the vaginal branches. And now we're going to attach the vagina back to that uterus. And so we do this in collaboration with our infertility doctors to make sure that these women are going to have a reasonable chance at a good fertility outcome. And these sutures will eventually dissolve. And you can see what it looks like. It looks like a normal uterus now. It's been reanastomosed to the vagina. The cervical cancer is gone. And these women can go on to have a pregnancy. And so this is my mentor, Nadim Abu Rustam, and this is a group at Sloan Kettering, and these are all the babies that were born following a radical trachelectomy. So these were all women who preserved their fertility and went on to have successful pregnancies. And every couple of years, we do an update of these photos. And so again, this having real world impact on these women and these families. So you saw before that we had that lymph node dissection and we kind of cleaned all of the lymph nodes off the vessels. And while it's a great surgery and I love doing it, we're probably over-treating most of these women. So we want to see, could we further tailor our sentinel lymph node evaluation? And so what we do here is we inject a green dye, and this goes now to that primary draining lymph node. And so We toggle between the white light to near infrared. You see that green picture, that's the dye that's going to these lymph nodes. And this is the first draining lymph node from the cervical cancer. And so that gets sent and it undergoes ultra staging. We're going to look here again, and it's not just enough you want to find that green lymph node. You really want to find that lymphatic channel that's draining and going to that first lymph node. We kind of borrowed this from breast cancer, right? Breast cancer has been doing this for a while, lymph node evaluation using Sentinel. They use the blue dye. And so here you can see again in the optic space that green lymph node looks a little bit enlarged, okay? So this is going to be removed, all right? And so the benefit of this is, one, you're not doing a completion lymphadenectomy, which, you know, in the past, we treated patients with cancer and we thought of side effects and morbidity after the fact. We were so focused on the cancer. But if you have a complete lymph node dissection and then you require radiation therapy, you can have up to rates of 30% lymphedema. Again, patients don't really complain too much. They're happy to be cured of their cancer, but now you've left them pretty debilitating lymphedema. So they forced us to do better, and this is what we did. So we've tailored our approach. And in fact, when we've gone on to look at this, you have a higher detection rate using sentinel lymph nodes than you do with a completion lymphadenectomy. And so this was our paper. It's one of the first papers that were published looking at sentinel lymph node evaluation in gynecologic cancers. And this has now become, again, standard of care. But yet we're still doing research. We're proud members of the Memorial Sloan Kettering Alliance. And so we have the SELECT trial, which is looking, again, idea of a real-world evaluation of sentinel lymph nodes in this collaboration with Sloan Kettering and the Mayo Clinic. And so we're happy to offer this to our patients. The surgery continues to evolve. And so for those of you that know cervical cancer, there was the LAC trial. And the LAC trial showed that if you did a minimally invasive surgery of cervical cancer, they had worse outcomes. But this didn't make any sense. You do minimally invasive surgery for urologic cancers and there's no difference in outcomes. Same thing with colon cancer. Something had to be different. And what was different, we thought, was exposing, as you saw in that radical trachelectomy video, that cavity to that cervical cancer. So I developed this technique where we use the robotic stapler, if you see there, and now staple across the vagina. And so at this time, you contain that cervical cancer. It's never exposed to the peritoneal cavity. So this is the robotic stapler you see here. When you fire this stapler, it does 1,000 readings per second of different data points to make sure that you have an appropriate and seal on that. So it's the same idea as you saw before in that radical hysterectomy specimen. We've done all that dissection. The difference is now we're not cutting across our probe like you saw in the previous video. We're now coming across with a staple to make sure that we have tumor containment. So we're not exposing the peritoneal cavity to any of these cancerous cells. We'll take a stapler reload. We'll come in now. And so again, towards us is the radical hysterectomy specimen, and then down is the vagina. So we're coming across that so that we can staple across and make sure that we maintain integrity of the specimen so it's never exposed to that peritoneal cavity. So this was presented at the Society of Robotic Surgeons. And with this technique, once we release the specimen, we then deliver it through the vagina. Patients are still able to undergo a minimally invasive approach with all the benefits of that, less pain, less blood loss, quicker return to work, but making sure that we have good oncologic outcomes. And so the Gynecologic Oncology group is now doing a trial to look at this. And one of the requirements of this trial is to use some kind of tumor containment technique, like using the robotic stapler, or some of our colleagues will go down below and kind of suture the vagina before they go across. And so this is a trial that we have open here. My friend and colleague Marla Taylor is one of the PIs for this trial nationally. So what else can we do? And I had a young patient, 32 years old, who was diagnosed with a vaginal cancer. The treatment for this is pelvic radiation. But again, that wasn't an option for her. And so what we decided was, could we do something else? What if we could move the uterus out of the pelvic cavity? She could receive her radiation therapy, and then we connected the uterus back. And this was first described by one of my colleagues in Brazil. Sloan Kettering has done 6 of these surgeries. And so I reached out to my friend, and thanks to our alliance, and discussed the case. And he thought that she would be a great candidate. And so you follow the same principles as you would with a hysterectomy. So we're opening up everything. But you want to be really careful they don't impact any of the blood supply. So we're going to dissect out the ureters. As you saw before, this is the round ligament, right? So we're going to come through this again with our electrocautery, all the while making sure that you're preserving the blood supply to the uterus. As you guys saw earlier, we had that probe in the vagina. You're going to take all this down. You're going to identify that uterine artery, which is the main blood supply. And this has been an evolution from what we did with the radical trachelectomies. We learned from our experience with the radical trachelectomy, you can actually take the uterine artery blood supply and still maintain enough blood to support the uterus and a pregnancy with the infundibulous pelvic ligament. So we kind of took what we learned from our radical trachelectomy and proceeded with this. So here we're going through the uterine artery. That's the main blood supply to the uterus. We're gonna go to the other side, same thing, open up that retroperitoneum. And again, you'll notice minimal blood loss here, right? You can see the fine techniques that we can use with robotic surgery. Patients go home the same day after this, okay? As you saw earlier, we're gonna develop that bladder flap, move that bladder away, okay? Again, taking that uterine artery on the other side, which is the main blood supply, but we know from our experience, you can still have collateral blood supply for that. So now we've made our anterior colpotomy, right? We're incising into the vagina. And we're gonna completely release the cervix from the vagina. This has been most commonly described for patients who have like a rectal cancer, right? In my case, my patient was the first that was done for a vaginal cancer. So you see, we've now released the uterus completely. We're now going to move it now to the upper abdomen. So you undock the robot, you rotate, you're now working up to the abdomen. You want to make sure that there's no tension, no kinks in that main blood supply, because that's infundibulous pelvic ligament. That's what's giving all the blood supply to the uterus. We want to have this fastened about a little bit superior to the umbilicus to make sure you get it out of your radiation field. Okay. So when it was first described, they actually would bring out the cervix through the umbilicus, and the woman would continue to menstruate. That was kind of messy. So we gave our patient Depolupron, which shuts down the ovaries while they're getting their treatment. You can leave the cervix inside. It's going to stop their menstruation. All right. So we fasten this to the anterior abdominal wall. There's the cervix. So now we inject that green dye that you saw, and that green dye just follows the blood supply. And you're going to see this uterus is going to turn green in a moment, indicating that there's good perfusion to the uterus, right? That we haven't kinked anything, that this is still a viable organ. So you can see that green coming right from the infundibulous pelvic ligament along the ovaries and now to the uterine fundus. This is a good indication that we've so far haven't messed anything up. And now we're going to fasten the cervix to the anterior abdominal wall. And all this done minimally invasively. So the patient went on to get her 6 weeks of radiation therapy. During one of her weeks of treatment, she came to the ER with some abdominal pain, did a CT scan. And they said, we don't know how to tell you this, but you have a mass in your abdomen. This is probably a cancer. And she said, no, that's my uterus. They said, what? I said, yeah, look at my operative report. They moved my uterus to my abdomen. So guys in the ER didn't do a good job getting a good history, but so completed her treatment. And then actually my friend and colleague, Mario Lateo, came down from Sloan Kettering. It's the first time we had a surgeon outside of Baptist Health that we got privileged for to operate here at Baptist. And we did the surgery together, robotically, a dual console. So this is afterwards. This is the second stage of the procedure. You can see you have some adhesions. You want to release all of these adhesions. Again, my scissors in the right hand. And that's that infundibulous pelvic ligament. That's the blood supply that's going back to that uterus, okay? And this is the first time this has been done in the southeastern United States. And this is the first one that was done for a GYN cancer. Sloan Kettering has done 6, but they were all for colorectal cancers. You want to release all of these adhesions. Obviously, we're taking our time. We don't do a lot of these. And there's no room for error here, but everything has gone great. So you want to release those adhesions, make sure you're identifying your blood supply. So now you've released the uterus. Okay, everything looks good. We're now going to move this back into the pelvis. Okay. And now we have to anastomose this back to the vagina. Now, the radiation oncologist will tell you that there are no side effects from radiation therapy, and they're right, but there is some scarring. So you want to do this about 6 to 8 weeks within then completing the radiation therapies. So that, again, as you guys know this by now, is the probe in the vagina. We're going to release that bladder away from our vagina, make our incision. My assistant's going to come in through the vagina. We're going to bring that cervix back into the vagina. You want to bring it a little bit into the vagina so as it heals, you have some space. And now we're going to suture the vagina to the top of the cervix there. Again, you want to be careful. There's still some vaginal branches, cervical branches. That's the only blood supply there. So you really don't want to injure any of that. That suture is a barb suture. So it has little barbs on it, holds in place. You don't have to tie knots, so it makes things a little bit faster in the operating room. And again, we're kind of not making this up as we go along, but no one's done this before. So really this is, you have to think this out before surgery and make sure you have a plan of what you're doing intraoperatively. We get that posterior bite, bring this together. Make sure that you close off all that area, but you don't want to do anything on the medial aspect where you might injure one of the arteries. Obviously, if she gets pregnant in the future, we need to have a cesarean section. She cannot have a vaginal delivery. But again, we're preserving her ability to have future fertility, which wouldn't have been an option with the traditional way that we treat this cancer. There's the uterus. We're going to inject the green dye again. You're going to see a transverse, the gray blood supply to uterus again. The viable uterus that now has been transposed back into its normal anatomical position. This is the first one done in South Florida, or in Florida. And we're really proud of this. And this is my patient, Courtney. This was pre-op with my mentor, Marla Teo, came down from Sloan Kettering. This was us and our team and our radiation oncologist, Yoni Weiss, who specializes in radiation therapy. It's a great asset for us to have. She rang the bell. I've never seen so many people there for a bell ringing in the 7 years that I've been here. And that's Courtney and me at our Panthers game. Yes, we have hockey down in South Florida. We're actually the Stanley Cup champions. And it was Hockey Fights Cancer Night. And she's been great throughout all this. And she shared her story and really trusted us. I told her, I've never done this before. And I don't know how this is going to turn out. But she believed in us, and we're really happy how everything has gone. So, you know, surgical innovation and fertility sparing, it's driven by patients. They're the ones that force us to think beyond what we know to do. We're moving towards less radical surgery, a more tailored approach, and it's really had a powerful impact. And you see that in those babies that wouldn't have been born otherwise, in Courtney, who has the ability to get pregnant in the future, and we're able to treat her cancer successfully. So thank you again for listening to this tale. I'm proud of the work that we've done.
What a fascinating case, and now you can understand why I said it's such a privilege to work with these luminary physicians and colleagues and do some of this groundbreaking stuff that we are so privileged to serve our patients. So on the same light, I'm my privilege or honor to invite Dr. Minesh Mehta, who is the Deputy Director and Chief of Radiation Oncology. He's going to talk to us about advanced cancer care access, the importance of comprehensive radiation therapy modalities, and why it matters.
Thanks, Manmeet. Thank you. So you saw a common theme in the two prior presentations. The common theme is the patient. And I think as cancer doctors, we are especially attached to our patients because they're fighting some of the most devastating battles that you can see in all of medicine. And so for us, the patients indeed become a very significant focus. And although the title of my talk is very technologically oriented, what I'm going to do is bore you in the first half with technology, but in the second half, I'll come back to their theme, the patients and the stories they tell. So this is us. We are a world-leading facility, 13 radiation oncologists, 24 medical physicists. It's the most comprehensive radiotherapy technology platform anywhere on the planet. We have a deep clinical research trial portfolio with national and international leadership and very impressive academic productivity. And of course, we do research, but we do research with one and only one goal in mind, and that is to change the care and outcome of patients. We're scattered all over South Florida. This is the geographic map of where we extend and the future sites where we're going to go. But a lot of you are from the Caribbean and Latin America, And as you can see, we already have partners in the Caribbean. Some of them are in the audience here. And we continue to grow and develop this footprint because we truly believe that we owe our neighborhood a debt of gratitude and a debt of collaboration. These are our cancer physicians spread across South Florida. And this represents the pinnacle of what we collectively as a group can achieve. That is the creation and generation of knowledge and the dissemination of it. Since 2017, when we opened the doors of this center, we've now published over 1,000 manuscripts, posters, and abstracts. And it's a true testament to the fact that we learn from our patients every day, and we publish our experiences and deliver results. We do this through the context of conducting clinical trials, and we are very robust about our clinical trial operation that is led by Dr. Manmeet Ahluwalia. We accrue. Every patient deserves a chance at a clinical trial. We are the first across Baptist Health in terms of clinical trial accrual at MCI. We are the first in the MSKCC Alliance for accrual, and we're top in the nation in some of the major cooperative groups. As a consequence, the practice, the volumes, the procedures, the strategy continues to grow. It doesn't matter which metric we plot, you see an upward trend. This perhaps is the most significant slide for a technophile. This represents that comprehensive technology platform that I mentioned to you. This platform doesn't exist anywhere else on the planet. Anything that you can think of in terms of a tool in the toolbox for a patient with cancer exists in this center. And what that means is when I see a screwdriver, when I see a screw, I pull out a screwdriver, not a hammer. But in many places, a screw and a nail look identical. And a radiation oncologist that only has a hammer is going to pull out a hammer both for a nail and a screw. And I think that that distinction is often lost to those who are not sophisticated or knowledgeable about the variations and differences in technology platforms. What I hope to do is to tell you why this actually matters. To do that, I'm going to start off with a quote from a physician. This physician happened to be a patient of ours who had traveled the world and had been told that his cancer could no longer be taken care of because everything possible had been done. We did something that made a difference, and at the end of that, this is what the patient said. He said, "I wish to applaud the culture that you have developed with the focus on world-class technical care, combined with world-class genuine hospitality, kindness, and empathy for the patient. A winning combination, unique in my experience, and quite noble." So as I mentioned, that was the boring part of the talk. Now I really want to tell you what I believe in, which is my patients. And I'm going to tell you this from the perspective of telling stories. Our best stories are told by our patients, and this is a statement I use with homage to Salman Rushdie. Those of you who know Salman Rushdie will know he's probably one of the greatest storytellers of this century, for which he has almost paid a price of his life by telling stories, but has managed to survive. He's a Booker Award winner and writes some of the best books ever. He says that the distinction between civilization and lack thereof is the ability to tell stories, because only mankind can tell stories. There is no other beast, animal, life form that tells stories. And to expand that further, I believe that our best ideas for our research teams come from our patients. So I'm going to start off by sharing maybe 4 or 5 of these ideas. This young lady, 10 years of age, came to us with the picture at the bottom in panel A with a tumor in her brain circled in green above. This tumor, of course, was growing in her brain and caused her to not be able to smile. At 10, going to school with your peers, this is a major disaster, especially in the world of social platforms and instant gratification by getting your pictures online the moment you wake up. She came to us after completing her course of radiotherapy when she was still unable to smile, and became the first pediatric patient ever to be put on an experimental drug, a slide of which Dr. Ahluwalia showed you, ONC201, and became the first patient to be treated with this. And at the end of 10 months, her smile returned. We've never seen this with brainstem gliomas. To be able to reverse cranial neuropathies is a phenomenal outcome. And this is now the basis of an international global phase 3 randomized trial. We were able to do this because at that point in time, we had no idea what to do with this patient. We said, when we don't have an idea, and those of us who are up here in front of you telling you these stories, we are telling you stories on behalf of our teams, because what we have is a lot of smart people behind us. So what we do when we have a problem is I turn around and say, can you guys please help? Because that's the easiest way for me to solve the problem. And at the center of each team is always a woman. And as you can see, Dr. Odia is the center of this team, flanked by Drs. Hall and Dr. Dagestani. And they came up with this idea of using ONC201 in this patient and brought her to the point where you saw her smiling again. This is the paper that you saw earlier. In fact, Newsweek labeled this as scientists find a new weapon against brain tumors, a major crack in the armor, and the global phase 3 trial, as I mentioned, is underway. Cancer of the pancreas is a disease that gives cancer a bad name. This patient in red in the center, Lady in Red is one of my popular songs, came to us with unresectable, inoperable cancer of the pancreas, having been told at a major cancer institute, NCI designated, that she was at the end of the road, and perhaps the only thing she could do is go to Miami Cancer Institute to meet this strange guy whose picture I'll show you in a minute, who's doing this strange stuff with this strange machine that nobody has really heard of. And she defeated inoperable pancreatic cancer to spend time with her grandchildren. And in fact, this coat is her coat. There was no pain or discomfort. In fact, I felt nothing when the radiation was delivered. And that's that strange machine. It's a marriage of an MRI scanner and a linear accelerator. It's known as the MR-Linac. And again, when we are faced with tough problems, I turn around, look over my shoulder, and find 3 people smarter than me and say, go solve the problem. And at the center is always a woman. So Kate Mittauer, flanked by Michael Chong and Adil Kaiser, came up with the concept of using aggressively hypofractionated dose-intensified radiotherapy, which is a mouthful. And all that it means is we give a lot of radiation in a very precise manner only to the tumor, not to the normal tissue, continuously tracking it with an MRI scan of the patient so that normal tissues are protected. This is a very, very difficult thing to do because the pancreas lives in significantly important territory right next to the duodenum. And if you blow a hole in the duodenum, that kills the patient. So this is kind of risky business, and that's why I have people like Michael Chong take the risk while I watch. So what does this do for patients? If you go to Memorial Sloan Kettering Hospital with this advanced unresectable pancreatic cancer, and this is a joint publication that we now have, your chances of surviving 2 years are 20% with standard chemoradiotherapy. If you come to Miami Cancer Institute using the MR-Linac, your chances are 2.5-fold better at 50%. This has now led to this being described in the most recent NCCN guidelines version as an effective therapy for pancreatic cancer. As of a week ago, this has now entered national guidelines. But the story gets better. The story gets better because 2 days ago, another therapy, electricity, and I'll tell you a little bit more about that in a bit, has been shown to have an impact in patients with cancer of the pancreas. This global trial run by a company known as the PANOVA trial showed a survival benefit in cancer of the pancreas. So we now have 2 things, electricity in this PANOVA trial, the MR-Linac approach. Guess what? This is the only center in the world where the PANOVA Plus trial of combining this electrical field therapy, tumor treating fields, with MR-Linac is currently active and recruiting patients. 2 days ago, news came out about the PANOVA trial. Yesterday, 4 patients walked out of their simulators in 4 different cancer centers and arrived at our center to be treated for cancer of the pancreas. And that's because we have the best reported results, as you can see here. This is a young attorney in her 30s. The MRI scan on the left shows you this ugly, bad-looking abnormality in white which is an extremely large recurrent malignant glioma. If pancreatic cancer gives cancer a bad name, glioblastoma or malignant gliomas are not far behind. They follow suit. This patient's disease was at 5th recurrence. So it's not the first time she was diagnosed, but at 5th recurrence. There is no known therapy that is effective in this disease at even 3rd recurrence, for that matter. And at 5th recurrence, she came to us, and we told her there's only one thing that can be done logically, and that's hospice care. She looked at us and refused to take no for an answer, and insisted that we come up with something. And as always, I looked over my shoulder, found a team, I'll show you the team in a second, and we came up with an idea and decided she would be the first in the world to be treated with this idea. The scan you see on the right is her scan after that treatment. The disease was completely eradicated. This is the team. I have to pretend to be the woman in the middle this time. Okay. Flanked by Alonso Gutierrez and Rupesh Kotecha. And we came up with an idea where we tweak proton therapy using a technology where we pulse the radiation beam, because the biology of pulsing radiation beams is dramatically different than the biology of continuously delivering the radiation beam. And this has now led to a successful clinical trial called the Popcorn trial that we're about to launch. I mentioned to you electricity. Let me take you back to ASCO 2023, 2 years ago, where a positive clinical trial using this electrical field therapy apparatus, it is known as TT fields therapy, was deployed as an adjunct with chemotherapy. Patients were randomized to standard chemoimmunotherapy versus the same therapy plus tumor treating fields for advanced metastatic non-small cell lung cancer. This is one of the patients that enrolled on the trial. Our center enrolled the largest numbers of patients on this trial in the United States. Dr. Kotecha was the PI on this trial. This trial, known as EF24, takes patients and applies electrodes. You can see in that picture, electrodes being applied to the patient's chest, and the electricity is delivered in a continuous manner to these patients. Here are the results. A significant survival benefit to patients that get tumor treating fields plus standard of care. As you can see, the survival benefit continues past 3 years all the way out to 5 to 6 years. A month ago, this received FDA approval. 2 weeks ago, we became the first center in the United States post-FDA approval to be able to offer this as a routine standard of care to patients with lung cancer. This concept of delivering electrical field therapy is infectious. They say that imitation is the greatest form of flattery. So because my colleagues were so successful, and because they're all a lot smarter than I am, I figured why not simply copy them? So together with Dr. Ahluwalia, I and some of my other colleagues were involved in developing this international global trial in patients with non-small cell lung cancer with brain metastasis, using, once again, this approach of using electrical current that's applied to the patient's head. So patients with a limited number of brain metastases receive stereotactic radiosurgery to control their disease and then proceed to get this electrical field therapy. These results were presented at the ASCO 2024 meeting. Here's the design of the study. Patients are randomized after stereotactic radiosurgery to receiving best supportive care or best supportive care plus tumor treating fields. And as you can see, with best supportive care, the progression-free survival in the brain is significantly better than it's much better with tumor treating fields combined with best supportive care compared to best supportive care alone. These data have just been presented at the ASCO meeting. They're in the process of being converted into a manuscript and presumably will be taken to the FDA for FDA approval. So this, if approved, could be another game changer in patients with brain metastasis. So with that, I'll stop here. We'll take questions in the panel session. And I believe it's back to you, Manmeet, for one more talk, I think. Thank you. Go ahead.
Thank you, Manesh, for sharing all the exceptional work you and your team are doing. And just continuing that theme of excellence, high touch, high tech, right? Because at the end of the day, we are living in the best era of mankind where we are having transformative changes in what we are doing in terms of artificial intelligence. And you're seeing that in technology. In fact, just to share a snippet, 2 decades back, the amount of knowledge we had in healthcare doubled every 2 decades. Do you know what time period it doubles now? Anyone has an idea? It's 72 days. Okay, every 72 days, we are doubling the knowledge or data that we have in healthcare. So imagine the unlimited potential we have to transform the outcomes of our patients. With that note, I want to welcome Dr. Murugasan Manoharan, who's the chief of our urologic oncology surgery program here. He's going to talk to you again, same theme, breakthroughs and innovations in prostate cancer surgery.
Thank you. Good afternoon, everyone. It's really a hard act to follow Dr. Minesh Mehta and his stories. We'll try our best. And today, I'm just going to talk about, we do a lot of innovative things and wonderful cutting-edge options for the prostate cancer treatment to enhance the outcomes for most of our patients. And I think there's a disclosure thing. I have nothing to disclose. Today, over the next 15 to 20 minutes, I want to cover only a few options we provide at Miami Cancer Institute, and particularly the focal therapy for prostate cancer using the irreversible electroporation, otherwise popularly called as nanoknife, and also high-intensity focused ultrasound ablation therapy for prostate cancer. I also want to cover a little bit about the improvements in the robotic surgery for prostate cancer and how we can also combine the theranostics in the treatment of prostate cancer to enhance and improve the outcomes. First of all, as all of us know, prostate cancer is the most common solid visceral cancer among men, and we have about 250,000 new patients are diagnosed every year, and we'll have about almost 30,000 people dying from the disease every year. We have several alternate options. We have surgery, like a robotic surgery. We have radiation, such as proton beam and a cyberknife. We have ablative therapy. We have active surveillance. We have hormone therapy. We have multimodal therapy. So when you have so many options, what are the issues? Why are we even very concerned about the treatment options? The problem is the prostate itself. The prostate is the most user-unfriendly organ for the surgeons and the medical oncologists, radiation oncologists, because it's located very deep in the pelvis. And when you look at the top of the prostate, the apex of the prostate, we have the sphincter. If you damage the sphincter, you get incontinence. At the base is the bladder and the ureteral orifices. Anteriorly, you have the bones which you cannot retract. Behind the prostate is the rectum where we don't want to hurt it. But more importantly, on either side of the prostate at 5 o'clock and 7 o'clock position, we have the nerves which are important for the sexual function, erections. And if you hurt the nerves with any treatment, it leads to erectile dysfunction. So this is the main reason. And even though I've said all these things, what are the main concerns about the treatment complications, particularly among the American men? This is the most common concerns for the men, and erectile dysfunction. However, we have other concerns, particularly urinary incontinence can be stress incontinence due to surgery or urge incontinence due to radiation, erectile dysfunction or bleeding due to the surgery or radiation, cystitis, bowel complications, secondary malignancies. So we have so many other complications, but when the patient is willing to go for the treatment for prostate cancer, the most important thing he wants is a durable cancer control. But that is not enough for the patient. They do look for further beyond the cancer control, the early return to activity, urinary control, and erectile function. As I mentioned earlier, multiple surveys in the US have shown that among all the treatments, they really look for a sexual function recovery as well. And we know that not all cancers need radical treatment. There are simple solutions for big problems. And on one hand, we have certain patients needing active surveillance. They may not be suitable for active surveillance, and they might be anxious, and there are some issues with active surveillance, including progression of the disease. On the other hand, the radical treatments such as surgery and radiation may not be acceptable to the patient and may not be needed. That's when the focal therapy comes into play. The focal therapy tries to address the cancer cure while you are able to maintain the quality of life. And
Ablation, I just want to introduce the topic to some of the people who are not familiar with it. Ablation means in situ destruction of the tissue. You can either destroy the entire or ablate the entire prostate, but that leads to destruction of the nerve bundles as well. Or you can do a partial or subtotal gland ablation where you at least preserve one neurovascular bundle for sexual function. Whereas the topic today we're going to talk about is a focal therapy where you want to select the cancer tissue with a rim of normal tissue around it, thereby protecting the nerve bundles and the sphincter on both sides. The salvage ablation means that somebody had a previous treatment such as radiation or another ablation procedure, you want to offer it once again, it's a salvage ablation. To make it simple, well, if you have a hemiablation, you destroy one half of the prostate and you preserve one neurovascular bundle, which is sufficient for sexual function. Or you can do a 3/4, like a hockey stick, a subtotal ablation, you still preserve one bundle. But in the focal ablation, you only destroy the tissue, the cancerous tissue, the rim of tissue around it, thereby protecting both the neurovascular bundle. We can use any energy source or a thermal or non-thermal to destroy the prostate tissue, which can include ice, cryoablation, or you can use heat with a HIFU, or you can use a radiofrequency ablation, interstitial laser, and microwave. And in non-thermal thing, one of the most important things which we're going to talk about is the irreversible electroporation or nanoknife. We also have a photodynamic therapy, and we have a radiation therapy such as stereotactic ablation and focal brachytherapy. Ablation, as I mentioned earlier, offers the potential benefits of the cure of the cancer while minimizing the side effects. So what is a nanoknife, which is it's a commercial name, and the real thing is the irreversible electroporation, where this is a focal non-thermal ablation therapy where we use a high voltage but low energy direct current. And when you do that, it produces permanent nanopores in the cell membrane, which leads to leakage of the cell and death of the cell immediately. So when you put the tissue in the electric field, what happens is that because of the electricity passing through, the cell membrane permeability and surface tension changes, and it produces the selective pores in the membrane. And as you can see in this slide, on the left side is a normal liver, which is a 20,000 magnification. After the nanoknife procedure or IRE procedure, you see the multiple nanopores. But in the prostate tissue and other things, these nanopore formations are very rapid. Within a few milliseconds, if you look at the second picture, the micropores, the nanopores start forming. By 10 seconds into 40 seconds, multiple pores forms. And very soon, within a few seconds, the cell starts leaking, and by 10 seconds, the cell actually dies and collapses. This is quite a wonderful technology to use in selected patients. Another important thing is that the IRE is a non-thermal. Usually, it protects the collagenous tissues and vascular tissue. Even if I have a big lymph node on top of the IVC, I can selectively ablate the lymph node without destroying the wall of the IVC. Usually, you get a regeneration of smooth muscles, endothelial cells within a few days to a few weeks. That is the biggest advantage. For example, if I do a nanoknife or IRE on the prostate, if I want to do a radiation or I want to do a radical surgery, you can still do it because the architecture and scaffolding is maintained. That is one of the best advantages of the IRE. So the machine we use it at Baptist, we are one of the early people who did the clinical trials for the nanoknife for the IRE at the Baptist Health System, and we are in the phase 1, 2, phase 3 trials as well. And this is a generator, is a very simple device which can be easily transported in the back of the SUV and other things. The main thing we need as a surgeon is the electrode, which is a needle we put in the prostate, which is similar to any biopsy needle. So you don't need any other bigger gadgets. You can do it in an outpatient setting or in the hospital setting as well. The key thing is very simple. You have it right in the middle, the yellow thing is a tumor. You want to capture the tumor by putting the needles around it and electrocute it. That is the main thing. If you put the tissue correctly, between the needles, the cell will die. It's very, very reliable ablation we can achieve. So for example, if the tumor is right in the middle, I place 4 needles all around it, and we pass the current between different needles, 1 to 4, 4 to 5, 2 to 4, things like that. And that leads to the death of the cell and death of the tissue as well. So one of the things which is happening is that we have the advances in technology. We are using artificial intelligence. We have the MRI findings. We all fuse them together to make this procedure easier and more specific, more precise, so that you can destroy the tissue without causing any side effects. In this particular things, we use a grid, and we have an ultrasound machine with MRI fusion, which guides the surgeon to place the needle correctly. This is exactly you see in the operating room as well. You see the tumor incorporated in the image with the MRI technology and segmentation, and using the grid system and other advantages, you can place the needle exactly. For example, you can, looking at the picture, I can place the needle at C4, and it exactly goes through that. I did a case last week, and this is the procedure we did that. You can see the red thing there, which is the tumor on the left side. And I can predict where to place the needles by looking at the grid, and with the AI things, you will be able to see in real time where the needle will go and whether I'm putting the needle exactly around the tumor or not. So it makes the procedure easy and more precise. Making a mistake by the surgeon becomes less and less. And once I've done this, I think there's one more video. So I'm placing the needles right now. It's quite a straightforward thing. It's a real time. I can see it on the video, and the AI and other things guides me as well. And you place the needle precisely around the tumor, and it confirms the position. And then all that you need to do is that ablate it with passing the electricity, and it's a very quick procedure. To ablate a 1 to 2 centimeter tumor, it takes only 9 minutes. And remember, the patient has got only the 3 or 4 needles placed, and they will be able to go home the same day. And this has got one of the best results with regards to patient recovery, getting back to work, and also like a urinary continence as well, and the sexual function. And the placement of the needle is reasonably straightforward as well. And but the key thing is that not every patient is suitable for electroporation or focal ablation. The key thing is that selecting the appropriate and the right patient. Once you choose the patient, you need to ablate the tumor completely. After ablating, remember, you've done only focal ablation, the rest of the prostate is still normal. You need to closely monitor them to make sure that the tumor does not appear, new tumors appear on the other side, or recurrence happens. So when you look at the results, I'll have a quick 2 slides. First thing is that the failure-free survival is at 5 years is almost 90%. The beauty is that even if the 10% occurs outside the field of treatment inside, we can still offer the definitive treatment such as radical prostatectomy or radiation treatment and various other things, or even you can reoffer the same IRE. Even for a group 3 one, the survival, disease-free survival is 80% and above. But more importantly, the functional outcomes. If you follow these patients at 6 months, more than 99% of the patients are pad-free, incontinent, and dry, and more than 90% of the patients have maintained the potency. And the 10% of the people who have rectal dysfunction can still be treated with other options as well. So these are the advantages of the irreversible electroporation. Moving on to the high-intensity focused ultrasound. In IRE, we use the needle, whereas in the high-intensity focused ultrasound, only thing we do is that we place a rectal probe to send the ultrasound waves. And this is again aided by the computer and the various other technologies. Once the patient is asleep, you put the rectal probe, scan the prostate. As a surgeon, I identify the tumor, I mark the tumor on the computer, and give the information to the machine. And this machine sends high-frequency ultrasound. It does a couple of things. First of all, it heats up the tissue where you're marked. It's very precise. And the temperature increases and leads to death of the cell at that area alone. Secondly, the high-intensity focused ultrasound causes oscillation and cavitation of the cells, leads to cell death. Within about 14 days or so, you will see the fibrosis taking place. But while you're doing the procedure itself, you will see that the tissue undergoing like a collapsing in size and shrinking in size as well, and you'll see it live as you're doing the procedure. Again, there is no needle, nothing else is involved. So the patients go home the same day, and they get back to work very quickly. And this is a position the patient are in, and that's a rectal probe. That's all the patient will have. And once we have marked it, you will slice by slice, the area where you're marked will be destroyed by the high-intensity focused ultrasound. Again, these technologies are very good, but as a surgeon, you need to choose the right patient, and you need to choose the right technology to treat the patient. And the high-intensity focused ultrasound, if you choose the patients wisely, again, the survival, everything is about 90% in 5 years and 7 years as well. And again, the continence and other things, the potency is very good, about 95%, 100%. So again, the technology is good, but you need to select the patient correctly and do the procedure well to achieve the best outcomes. And moving on to, like I have another 6 more minutes, robotic surgery. Last year I spoke about robotic surgery. So this time I just want to spend 2 minutes. At Baptist, we have almost every single platform available to perform a very good robotic surgery. We have a Da Vinci 5, which is the latest one we have. We have a single port robot, and we have a multi-port versatile Da Vinci Xi robot as well. All the technology is available, but it's up to the surgeon to use the technology wisely to get the best outcome possible. So in the robotic prostatectomy, there are 2 things that are very important other than the cancer control. One is the sexual function protection, which comes from the nerve sparing. You need to do the nerve sparing only for the appropriate patient. You cannot randomly do for every single patient. If the patient is suitable for the nerve sparing, as a surgeon using the robot, you can do very well. As you can see that the sexual function nerve comes from the sacral routes, and these nerve bundles are very thin, like your hair fiber, and they are draped on the prostate on either side at 5 o'clock and 7 o'clock. And using the robot, which has got 12-fold magnification, and you don't have tremors, 4 hands with a precision accuracy, these nerve bundles can be identified and treated. Here you can see that the prostate, I'm very close to the prostate. You don't even see the nerve bundle right now. These instruments are very small. The tip of the instrument is only 1 millimeter. Very fine and gentle moves. You will be able to separate the nerve bundle from the prostate. It takes a minute or so to do this, but you keep the left hand steady. But if you do a very, very gentle moves, you will be able to separate the nerve bundle. Now you can see the nerve bundle separated, and we are still doing that. And at the proximal end will be the blood vessels to the prostate, which will clip and divide. You'll see it. But the entire bundle, by very gentle moves, this is very deep in the pelvis, so you can't see very well if you're doing an open procedure. So I'm clipping the neurovascular pedicle for the prostate and dividing it. But whereas I'm separated the bundle and kept it separate, you can see the bundle on the left side very clearly seen and separated, and you're maintaining this whole bundle completely, and you remove the prostate and the bundle is preserved very well. So that is one of the biggest advantages of the robotic prostatectomy. The second thing is that you want to do is the maintenance of the continence. The main thing with the continence is that puboprostatic ligament complex, which is you're seeing right thing, the white thing. Normally we tie the whole thing and divide it, but at the Baptist at MCI, we have a new technique where we preserve the puboprostatic ligament, which you see in the white in front. We put the stitch behind it completely, and so that the puboprostatic ligament is preserved, just like Dr. John Diaz preserved the uterus, we preserve this ligament. And after dividing it, removing the prostate, we actually put it back and sew them back together. So that way, the puboprostatic ligament is preserved and re-anastomosed. So this single-handedly just changed the continence in the patients. And in our centers, like many other centers, at 6 months, the urinary continence level is almost 98%. Not almost, it is 98% at this moment. So you can see that I'm dividing the puboprostatic ligament, preserving it, only removing the prostate completely. And the prostate is the one which is going to come out. And once you have done that, you're going to re-sew the whole, the puboprostatic ligament back to the bladder neck so that you restore the anatomy and you restore the continence for the patient. And just because I have only 2 more minutes, like now you can see that I'm doing the anastomosis. And then once the anastomosis is done, we sew it back to the puboprostatic ligament, which you'll be seeing it in a second. And again, this is very deep in the pelvis and the needles are so small. And we have done the anastomosis, and after this, anteriorly, you're having the puboprostatic ligament, which has been preserved. Now we are sewing it back. So you're restoring the anatomy as before. Lastly, I just want to bring a quick thing about theranostics. Many of you will be familiar with the theranostics. Briefly, when you offer the patient systemic therapy, such as chemotherapy or immunotherapy, it works for the entire body. It affects the cancer cells, it affects the normal cells, and you might get side effects. But if you combine the therapeutics and diagnostic agents together, that's what is called as theranostics. For example, in prostate cancer, we have a PSMA, the antigen and other agents, which are diagnostic agents, which specifically goes only to the prostate cancer cells, such as this. So like a PSMA, we use gallium pylori-5. These agents are diagnostic agents, which specifically goes and attaches only to the prostate cancer cells. And then we have a therapeutic agents. For example, you have lutetium-177, etc. And when you give it to the thing, normally they go to the whole body, all the cells. But when you combine the therapeutic agent with a diagnostic agent in prostate cancer, They specifically go attached to the prostate cancer cells only and then destroy the peripheral cancer cells, thereby minimizing the side effects at the same time increasing the efficacy. So how can we can use any number of agents. You can use CAR T cells. Many other things can be used by attaching these therapeutic agents to the nanoparticles in the diagnostic agents. So in our center, we have a number of multidisciplinary collaborative approaches, and I just want to share one because of the time. And we have a very, very intelligent person from the radiation oncology by name Dr. Adil Kaiser. And he has got a wonderful thought. I'll give an example and I'll finish with that. For example, this patient is a 55-year-old gentleman. He has got a prostate cancer along the anterior aspect, which is very localized, but it is a very aggressive, high-risk localized cancer. But it is Gleason 9. Because of that, there are high chances of systemic disease, micrometastasis there, and you might have a multifocal other cancer in the rest of the prostate as well, which we are not diagnosed yet. This patient does not want to have the prostate removed. At the same time, you want to be treated well, both for local disease as well as systemic disease. And at the same time, wants to have his continence, wants to have things. What can we do? This is what Dr. Kaiser is proposing. So what we would like to do is that because the disease is localized anteriorly, I can use irreversible electroporation nanoknife to destroy that cell within the prostate. Then we can use theranostic approach to kill any microscopic micrometastasis. And then we can also give, instead of giving a full dose radiation therapy, we can use a low dose therapy for the prostate to affect the multifocal disease which might exist. So we are addressing all these three things together at the same time preserving the sexual function as well as the urinary continence. So we have a number of other options available for future, but stay tuned. Thank you very much for your attention.
Thank you, Dr. Manoharan, for all the exceptional work you and your team doing. Continuing on this theme of excellence for our patients through breakthroughs, we are going to invite next Dr. Gunther Kuna, who serves as the Chief of Bone Marrow and Transplant and Deputy Director of the Miami Cancer Institute, to talk to us today about revolutionizing cancer care, stem cell transplants, and immunotherapy breakthroughs.
Thank you. My pleasure to be here and happy to have you all back or be here in Miami. Before I get into my field, I listened to Dr. Mano and Dr. Diaz and saw the video clips. I thought, thank your God that you didn't ask me to become a surgeon because you don't want me to cut your turkey. And so I ended up in the bone marrow transplant and stem cell transplant field. But my task for today is broader than just focusing on one disease, and that is hematologic malignancies. And that's a very broad spectrum of different diseases. They are all different, from lymphoma to multiple myeloma, leukemia, myelodysplastic syndrome, myeloproliferative disorders, and so forth. And even in between the diseases, they're not all the same anymore. Years ago, we had multiple myeloma. We did one treatment, and then we had a second one, and that was it. Leukemia were all the same, and today, with the rapidly changing landscape, it's very detailed and oriented towards high risk versus intermediate risk versus not so high risk diseases among all the entities. And I thought that to just give you an update on where we are with some examples and indicate also that the time of more chemotherapy is completely over in our field. It's all immunotherapy directed. And I was happy and lucky enough, and we heard about MSKCC, to be there for 23 years before I came here and developed a lot of immunotherapies in the transplant field and post-transplantation approaches. That has all been published. I don't have to convince you about this one, but the platform was generated, and today it's really where we are. And I'd like to give you one example for multiple myeloma, if you can remember. So first question we ask, induction chemotherapy, then consolidation, then autologous stem cell transplantation, and then maintenance treatment. And that is still the case, but the drugs that we are using are very different now. It's not chemotherapy. Every patient that comes for myeloma treatment talks about chemotherapy, but there's not a single chemotherapeutic involved. because we're doing Revlimid, we're doing Velcade, we're doing daratumumab. Those are all immunotherapies if you want. And so that is a big change. Autologous stem cell transplantation is continuously under debate, but it will not go away. And autologous transplant for multiple myeloma and the complexity or morbidity that is less than 1%. So why are we really asking whether or not we should do autologous transplants or not? And lots of my patients are more than 5, 6, 7 years out following autologous transplant and have never been readmitted or any complications post afterwards. So for me, it's a no-brainer. We will continue. But on the next slide, that is the novelty here. So when patients relapsed after autologous transplantation just 3, 4 years ago, we were kind of in trouble, said, what's next? And we didn't really have that much. But today, you can see here we have treatment for a first relapse. We have a third relapse treatment option. We have a fourth relapse treatment option. They're all immunotherapeutic directed. And the question that we are really asking today is, what should we do first and what is best? And that is under an international assessment right now. And again, the field is developing so fast, it basically changes within a few weeks. But so to just to show you the difference, I thought I'll give you a case which is pretty much standard. As you know, a 60-year-old male patient comes, gets diagnosed with multiple myeloma, cytogenetic translocations 414, 1416. That makes it high-risk multiple myeloma based on there. On top of it, TP53 mutation and gain of 1q. That's basically all of them are high-risk markers that prompt us to say, okay, you're not going to get double treatment or triple treatment. You get quadruple treatment in the beginning for induction. That is daratumumab, Velcade, Revlimid, dexamethasone. This patient got exactly that, 4 cycles, then got autologous stem cell transplantation, was still minimal residual MRD positive afterwards. And for that reason, the patient got on daratumumab maintenance in combination with Revlimid and promptly relapsed a year later. So what do you do there? So, okay, you'll say Dara is one, isatuximab is another, CD33-directed antibody, but different binding sites. So we'll switch to a different regimen. Did this, and patient promptly relapsed 6 months later. So what now? Well, what would we have done 5 years ago or 6 years ago? We would have said, well, let's keep you comfortable for as long as possible. We can keep you on steroids and maybe if and here and there, but that's really all we can do. So what do we do today? We're asking, or I ask you, what would you do? Repeat autologous transplant? Not in relapse disease. Allogeneic transplant? Well, maybe. I led a clinical trial at Memorial Sloan Kettering Cancer Center for multiple myeloma with allotransplants. Transplanted quite some, the only place in the country. And I still get Christmas cards from patients that are 15 years later in complete remission. But it is complicated, so not every center would do it. But now we have bispecific therapies, BiTEs, so to speak, or we have CAR T-cell therapy. So, well, I just had a patient a few years ago, put her on bispecific BCMA, B-cell maturation antigen-directed treatment called elranatamab. You may have heard about it. Teclistamab is another one that is BCMA-directed. But you have choices. We have antibodies. Well, we use them. Daratumumab is a naked antibody, not necessarily indicated anymore. Antibody-drug conjugate, we heard about it a little bit. We have a toxin conjugated to the antibody. The antibody binds to the cell. The toxin gets absorbed and kills the tumor cell. Or we have what my expertise more, or my specialty is we have a T cell that we direct to the tumor cell, and that is through the bispecific antibody. So we have an BCMA monoclonal antibody, on the other hand, a T cell, and with that, the T cell gets to the site and recruits other T cells to the side of the plasma cells. Now, the CAR T cells or bispecific antibodies here, as mentioned, is the principle. You not only get the T cell with the antibody to the myeloma cell, but once you release the cytokines at the site, other endogenous T cells will be recruited to the site, and with that, you get a complete remission, hopefully. The fact is, yes, we did. And one aunt of one of the staff members in the room was one of the patients that I treated with relapse disease after autologous transplantation, and that is unbelievably 3.5 years incomplete remission on elranatamab, not complete remission, stringent complete remission, which means as minimal residual disease negative. That is something that we would have not seen 4 or 5 years ago, I would say. That raises question which we haven't answered and may not be able to answer or may not be gutsy enough to answer. That is, okay, 3.5 years, should I stop the treatment or do I have to continue? We don't know. I don't really want to stop it because it's well tolerated. Quality of life is 115%. So why should I stop the treatment and keep her or take the risk not to keep her in remission? So changing landscape significantly, and now we are assessing combination therapies of BiTEs with other drugs that we have. Another example, switching to lymphoma real quick, 66-year-old diffuse large B-cell lymphoma, diagnosed stage 4, standard of care R-CHOP times 6 cycles. That's what we used to do and still doing it. And then the patient gets a PET scan and has relapse disease. And here we ask then the question, what do we do? Well, chemotherapy with R-GemOx, autologous transplant, allotransplant, CAR T-cell therapies. What would we have done 5 years ago? Well, we would have likely given chemotherapy and then an autologous transplant. Not 5 years, 3 years ago, we would have given chemotherapy with rice, which was a standard, and then a beam or R-beam conditioning, autologous stem cell transplantation, or a allogeneic stem cell transplant. We don't do that anymore because now we give CAR T-cells. And the principle is shown here. As you may know, CAR T-cells are gene transduced cells to bind to the tumor site. Here it's an antibody that's get introduced into the CAR T-cells by gene transfer. And with that, the antibody binds to the lymphoma cell, which is CD19 expressing or CD20 expressing or CD22 expressing. And the CAR T-cell goes to the tumor and induces a complete remission. Well, that is a completely new approach that is also under evaluation. We have a clinical trial now here at the site where we don't do one CAR T-cell binding site, CD19. We have a dual specific CAR T-cell, which is CD19 and CD20 at the same time, because we know if you relapse after CD19 CAR T-cell, most of the tumor cells don't regulate CD19, and with that, there is a very limited chance to get them back into remission. We call this tumor escape. So with dual specificity, that may be reduced, and the clinical trial is in full swing, and you will hear about publications coming up pretty soon. Now, not to confuse you even more, but over the last 5 years, there were 6 CAR T cells approved, shown here for multiple myeloma and lymphoma. And the question here is one better than the other, or is the one less toxic than the other? And talking about toxicity, it's a problem, different. And I have to say, myself and everybody else has completely underestimated the toxicity of the CAR T cells and the bispecifics. So don't do this in your clinic or don't do it in your practice. You need to really have an experienced hospital or affiliate that can do this. The patients can be sent back to you afterwards. If they send them to us, we don't steal the patients. We'll treat them, get them in the remission. You do the follow-up, and we can by Zoom or whatever have discussion on what to do next. But it's known that the cytokine release syndrome is one of the complexities, and the neurotoxicity is another one, which you all heard of. Cytokine release syndrome starts with a fever, and within short time period, 24 hours, the patients get respiratory distress, get intubated, and end up in the ICU if you don't know that it's CRS and you think it's an infection, and you start on antibiotics and hope for the best, that patient is dead. And so the neurotoxicity here also is another complication that they don't recognize when you come in the room. And some patients are happy not to know who the wife is anymore, but it's a neurotoxicity that is reversible with the appropriate treatment. We learned about this. But CRS and ICANS, as just summarized, can be treated. Tocilizumab for CRS, corticosteroids for the neurotoxicity, but not shown here. And I'm personally really surprised by the complexity in terms of infectious complications. We have all the viral reactivations seen, including adenoviral encephalitis, CMV infection, CMV encephalitis, EBV lymphoma. Every stuff that we know from allogeneic stem cell transplants can develop as a consequence following the CAR T-cell therapy or the bispecifics. So you need to know about it. Our infectious prophylaxis is equivalent to patients that underwent allogeneic stem cell transplantation because of the reactivation rates and the complications to be expected. Now here's my other one, just to jump into acute myeloid leukemia and the rapid changes that we have seen. And you may remember for 30 plus years, 7+3 was the only chemotherapy combination that was Downo and RRC, the only combination that was administered to patients with AML. And then at some point, before I came to Memorial Sloan Kettering Cancer Center, they started this allogeneic stem cell transplant program that was then accepted as a standard of consolidation therapy. But if you look forward, then now over the last 5 years on the right, all hell broke loose. And here we have alternatives that we have never dreamt of. And they are, again, not chemotherapeutics. They are, with the exception of CPX-351, which is liposomal 7+3, if you want. But gemtuzumab is an antibody against CD33, midostaurin, gilteritinib, anti-FLT3 antibody. And then we heard about already in the solid tumor field, the IDH inhibitors and IDH1 and IDH2 for patients with acute myeloid leukemia. Now, having said that, I mentioned that before, not every AML is created equal. We have completely different strategies for patients that get different forms of mutations or gene fusions in their disease. You can see there are some good risk markers like CEBP alpha. IDH2 inhibitor or IDH2 mutation is a relatively good prognostic marker, but you can, in contrast, also see that, for example, TP53 mutated AML is really bad. And no matter what you do, TP53 related AML or mutated AMLs relapse even after allogeneic stem cell transplantation within a very short time period, which then prompted us to say, why don't we do something like immunotherapy in the field of acute myeloid leukemia, maybe after transplant? And that induced the question, what can we do? Well, we can target leukemia cells specifically based on a marker that is expressed on leukemia cells, which is called CD33. But CD33 is also expressed on the normal hematopoietic stem cell. So that induces a real problem, unless there is a way to downregulate the expression of CD33 on the hematopoietic stem cell, and then transplant patients with CD33 negative stem cells. And we know now, and I'll show you some evidence, that all blood products derived, or all cells derived from the CD33 negative stem cell is also CD33 negative. So that leaves cells in the bone marrow that are CD33 positive are only leukemic cell populations. That was the theory. Now the question is, can we do that? Yeah, we can, because we have CRISPR technology. So we can downregulate the CD33 expression in the hematopoietic stem cell with gene editing by silencing the expression. Before we can do that, we select the stem cells by CD34, have a purified stem cell product, not the whole bag. We just have, all the million cells, and then we can do the gene editing. That principle of CD34 selection was established by Dr. Kona at the Memorial Sloan Kettering Cancer Center before he came to Miami, and now it's the principle of this clinical trial where we select the stem cells, gene edit, and then try to target CD33 specifically overexpressed and remaining on AML population. So the first question is, do patients survive without the CD33 expression, or do the hematopoietic stem cells survive? Does this guarantee a normal immune reconstitution or a normal count recovery? The answer is Yes, I'll show you in a moment, but here we have then the principles of the CRISPR-Cas9 editing, silencing, purify the stem cells, as you can see, do the gene editing, and then we have the stem cell product that is CD33 negative. And here we now did 25 patients transplanted with the stem cell edit around the country, not by yourself only, but around the USA. I will present this in a week from now at ASH in a real updated presentation. Very exciting stuff. I just picked the first 3 to show that it got all confirmed that here the immune reconstitution and the count recovery was absolutely the same than after non-CD33 edited transplant products. But more importantly, here we also added gemtuzumab after the treatment, which is an anti-CD33 directed monoclonal antibody, and could show that it did not affect the platelets or the neutrophil recovery in any form or shape. The patients did also not get any liver abnormalities, which was a problem at high doses of gemtuzumab administration in earlier trials. But interestingly, I show you this one. You see here the percentage of the CD33 positive cells, negative cells after the transplant. You see that it's ranged at an early time point from 90% to 35%. And when we administered the gemtuzumab, it went up to 100%. So that means that the residual CD33 positive cells were eliminated through gemtuzumab, and therefore we increased this outcome to 100% of CD33 negative cells in the blood and in the bone marrow. Now the final subsequent clinical trial is then that we do this transplant. If they relapse after transplantation while on gemtuzumab or even before they started it, we now can generate CAR T cells from the same donor targeting CD33. And that is the whole principle that we now have 2 clinical trials. And long and behold, I can honestly and proudly tell you the first patient in the world that got CAR T cells that are CD33 directed against relapsed AML after a CD33 depleted transplant is in the hospital right here, right now, 6 days or 7 days after the CAR T cell infusion, is doing good, but obviously too early to conclude whether or not this disease remains whether or not he remains in remission and whether or not we get him back into remission. But he knows, and we know, that without this alternative, we would have had a real discussion and say, what can we do and how can we keep you comfortable? Here we have another chance, and I'm very optimistic we get this man back into a complete remission. So finalizing this, 28 seconds left. BMT immunotherapy program at Miami Cancer Institute, not here. We are growing fast. We are changing fast. You need to all stay on top of it, and maybe you can't. But the reason why I have this Wall Street Journal article just came out 3 weeks ago, maybe 4 weeks ago. There was a patient who lived in Utah and sought a second opinion at an academic center, and the complete strategy of this treatment approach was changed rapidly, immediately, and for that reason he survived. Then it came out that Memorial Sloan Kettering Cancer Center, MD Anderson, they get lots of second opinions, and they found out that about 25% in all cases they have to change the treatment approach completely. You don't want to lose out to be in that field. So that is what I'm urging. If you have to stay on top, and the best way for you to stay on top is join my symposium that I have every year in March here in Miami with the top physicians around the world. I don't have to read you all the names, but Michel Sadelain, I like to point out, is the father of the CAR T cells. His laboratory was next to mine at MSKCC when he walked over and said, I have this funny idea to put an antibody into a T cell. What do you think? That sounds great. Well, great for him, because he will likely get the Nobel Prize pretty soon. But all the other ones here are friends of mine and colleagues from leading institutions that present update on all the heme malignancies. And I encourage you, if you can, come. It's a day and a half and you'll come home and you are up to date with everything. Thank you very much for your attention.
Thank you, Dr. Runa, for that riveting overview of heme malignancies. And with that, I would like to invite Dr. Jane Mendez, who's the Chief of Breast Surgery here at Baptist Health Miami Cancer Institute, to talk about Beyond Biology, shaping the future of breast cancer diagnosis and treatment.
Good afternoon, everyone. Time to wake up. Buenas tardes. Thank you, Dr. Ribas and the whole Baptist Health International for having me this afternoon. I'm going to, in the next few minutes, tell you a little bit about breast cancer we have to offer here at Miami Cancer Institute. So here's the building. In October, we always dress it up in pink in awareness of breast cancer. And some of you got to tour the building, but we house our services on the second floor. And what's most important for me is not the elegance and the beauty of the building, what happens within the building. From the minute I started 7.5 years ago here at Miami Cancer Institute, I was struck by the aesthetics of the architecture, but I knew what was most important was what we were going to be doing within that building and how we were going to grow. So in the next few minutes, I'd like to tell about the burden of breast cancer worldwide, what's the importance of the multidisciplinary approach, and then explore existing as well as future challenges that we still have despite all the advantages. So every 2 minutes, the time it takes to boil an egg, a woman gets diagnosed with breast cancer in the United States. If you take that number worldwide, it's even faster. 1 in 8 women will be diagnosed with breast cancer during their lifetime. We know that African American women have 42% higher risk of dying from breast cancer as associated with Caucasian women. And we know that is the most common cancer in Latin American women and the #1 cause of cancer death in Latin women. We know that the likelihood of developing breast cancer increases as we age. As you can see here, and when you're 50s, we expect 1 of every 50 women. When you get to 70s, 1 of every 14. And by the time you get to 80, it's 1 of every 10. And that's without any other risk factors. So the 2 main risk factors for breast cancer are being a woman and getting older. And unfortunately, we cannot change either. And I like to also, this is a very educated audience, but to stress again, most breast cancers are not familial or genetic. 85% are sporadic. They happen out of the blue. So certainly it's very important. A lot of women come to my clinic. I don't know what I have breast cancer. I don't have it in my family. So it's a moment when I educate the patients that 85% you don't have it in your family. You're the first case. And also lately, we've had an increase in male breast cancer. I don't know what are the factors attributing to this, but I had a 53-year-old triathlon athlete who thought he had a pimple in her breast, turned out to be stage 4 breast cancer. So certainly men, if you feel something, say something, because we have been seeing an increase in male breast cancer. And it does not matter where you are around the world, breast cancer accounts from anywhere between 19 to 28% of cancers around the world. It doesn't matter where you are around the globe. And unfortunately, we know that in our countries, South America, Central America, Caribbean, and others, we still see a lot of late stage presentations of breast cancer. I travel to a lot of these countries, and I always like to learn about the local numbers. And it's sad to see that in a lot of our countries, we see 60, 70% advanced stages of breast cancer at presentation. And we know there's no doubt that the likelihood of your outcome and your survival is linked to your stage at presentation. And in developed countries, we can see up to 80% survival rates in high-income countries, whereas in low-income countries, that can be 40% or less. So certainly, this can be attributed to a lot of factors, certainly access to care, technology, education, prevention strategies. We certainly, in some countries, we don't have the resources, but it's really important to continue to disseminate early detection is key in order to continue to improve these outcomes. So nobody will argue with me in this room. #1, everybody has probably seen somebody who has breast cancer. And when a woman feels a lump, it's urgency, it's anxiety. They want the lump out, okay? But we have to do our job. As a clinician, I have to make sure if this is a benign lump or is this a malignant lump. So we have to do the appropriate workup. Gold standard is mammogram. And here at Miami Cancer Institute and Baptist, we have 3D mammography. Sometimes we need to complement the mammogram also with an ultrasound. We know that breast sensitivity lowers the sensitivity of the mammogram. So in women with dense breasts, we have to complement that with an ultrasound, which gives us a lot more information. And then we can perform minimally invasive techniques like core biopsies so we can establish the diagnosis. We have 3D mammography in all our facilities. So certainly has really helped even find the cancers earlier. And in some instances, we might use breast MRI. That is not a screening technique because it's too expensive. There's 24% of false positives, but certainly has a role to play in certain segments of the population. And there's the million-dollar question. Women don't like to be squeezed, okay? Are there any other modalities that we can use to help us detect breast cancer? And actually now we're going to introduce what's called contrast enhanced mammography. We're actually having conversation with our breast imagers to see what's going to be the criteria, but we're introducing this in our armamentarium for breast imaging. It's kind of a cross between a mammogram and an MRI. As the patient will get injected with contrast, we can see better vascularity and more details than just the standard 3D mammography. So stay tuned, but that will be added to our armamentarium. But for the meantime, ladies in the audience, the mammography will remain the gold standard up until we have better technique. So it's a necessary evil. So I'd like to change gears a little bit and to talk about the importance of the multidisciplinary approach. Certainly, this has been an evolution of care from the very radical procedures of the Holstidian era to the more tailored approaches, a multidisciplinary approach that we've seen in the modern era and that we practice now. The gentlemen in the center are Umberto Veronesi as well as Bernard Fisher, who were the ones who started challenging the dogmas at the time and questioning, is there a role for chemotherapy? Is there a role for radiation, rather systemic approaches and more local control rather than these massive operations? And then the gentleman on the other side, Dr. Armando Giuliano, he's the one who introduced the sentinel lymph node biopsy, who certainly changed women's life and not exposing axillary dissection to all our patients unnecessarily. And they conducted really pivotal clinical trials that have changed the face of the practice of breast surgery. And it's all about the multidisciplinary approach. I cannot do my job without the medical oncologists, the radiation oncologists, the plastic surgeons, the pathologists who are busy, the breast imagers who are the ones who first place the diagnosis. So it really takes a village in order to provide our patients with the optimal care. And certainly how we treat the patients also varies. Sometimes we give chemotherapy first. Sometimes we might perform surgery first. For those patients who are ER positive, the hormonal therapy. So there's so many options that we have. And it's all about personalizing the patient, not only to the type of cancer that they have, but also any other medical problems that they might be dealing with, so we can really optimize their cure. And we've learned a lot about the past decade about the different types of breast cancer. Before, all the patients got treated the same. Certainly now we know there's 3 major types of breast cancer. We have the ones that respond to estrogen, the ones that don't respond to anything, that is called the triple negative, and the HER2, and those only account for about 15% of breast cancers. So understanding the biology heterogeneity Dr. Cohn was talking about understanding the hematologic malignancies gives us an opportunity to further tailor the care to minimize side effects at the same time that we're maximizing outcomes. So one size does not fit all. You see it again. So it's about finding those specific targets. So for the ER-positive tumors, those that respond to estrogen, we have the endocrine therapy, the aromatase inhibitors, the tamoxifen, and obviously for the HER2, we have the Herceptin, trastuzumab, and other factors that really help us target the treatment. And the goal is the following: we maximize the breast cancer cure while we maintain the quality of life. Because we know with everything, there's a price to pay. With every treatment, there's some side effects, and it is our job to be critical about where we begin our patients, where we can maintain this balance. So I want to give you a couple of examples what we do. Every Friday, we have a multidisciplinary tumor meeting where we discuss difficult cases so that we can decide as a group what is the optimal care for that particular patient. So I'll give you a couple of examples. So the elderly, we know every woman 70 and older need for me to check their lymph nodes. We know that if I do a sentinel lymph node biopsy, I will increase their likelihood of lymphedema, which will be in the order of about 5%. So will that really change the patient's management? So one of the recommendations for choosing wisely is for women 70 and older, really be critical. Do we really need to be doing a sentinel lymph node biopsy in that patient if they have a small tumor, if they respond to estrogen? Is that going to change their management? Another example, ductal carcinoma in situ is stage 0 breast cancer. And there's a lot of ongoing clinical trials right now to see if there's a subgroup of patients who have ductal carcinoma in situ stage 0 that has a great prognosis, in which they have such good characteristics that we might be able to avoid any surgery. Might it be that if they respond to estrogen, it will do just with the endocrine therapy? Can we keep them at bay? So that's ongoing. We're looking forward to finish the accrual, and we're waiting for those studies results to be published to see, is there the fact that we don't need to do anything, just give them a pill and keep them afloat. Age. So my oldest cancer patient here has been 99 years old. The youngest one, 21. Okay? And we need to tailor the therapy to that patient also based on age. So the 99-year-old, she had a lump. She had been delinquent for a grand total of 99 years. That was her first mammogram ever. And the reason why she decided to have the mammogram done, because it was hurting her. I'm not joking. Her lump was the size of a grapefruit. And I was hoping she would have an estrogen receptor positive tumor. So I could just keep it at bay with the endocrine therapy, alleviate some of her pain, and avoid any surgery. But to her dismay, it came back at triple negative. So then this was during the pandemic, and I presented the tumor board. I said, I have this 90-year-old, she only takes an aspirin a day. Her brother lived to 104, her sister lived to 105. She's a triple negative, and she has pain, she's symptomatic. So the tumor board's decision was, yes, let's offer her an operation. Then I said, I'm not operating on you unless all your family is on board. Okay, this was October, and she was going to be 100 in 6 months, March 10th. And I said, well, provided your whole family is on board, then I'll be happy to operate on you. So she had an operation, and she went home the same day. Mastectomy, went home the same day, and when she came for her post-op appointment, said to me, doctor, I made a decision. I said, what is that? If I win the lottery, I want you to reconstruct my breast. And I'm like, okay, that's the spirit. 99, but nobody was stopping her. Now, this 21-year-old is a slightly different story, but she had a mass, and they had told her that it was a fibroadenoma, and I was seeing her for a second opinion. And she had a family history of breast cancer, and her mother had the BRCA gene and had been treated already prophylactically for her genetic mutation, but she had never had cancer. So I said to her, you know what? They're recommending 6 months, but why don't we do a biopsy? It's so easy to do a biopsy. You've had the mass for a long time. You tell me it's enlarging, and we need to get to the bottom line. She was actually studying to take her MPAS to attend medical school. Make a long story short, she listened, she followed my recommendation. It was not a fibroadenoma, it was a breast cancer. So in that group, we need to really focus on the patient because there are many different issues, different from somebody who's already menopausal. We need to talk about having children, so fertility becomes really important, about her body image, about reconstructing her whole, about the sequela, because she has many more years ahead of her to live. So certainly we're actually creating a new program that's going to be geared for the young women with breast cancer defined as 45 and younger. We can really hone in the specific needs of the women who are young and have all these other issues to address. So with that, we need to reduce the collateral damage. I think I made the point. Also from the chemotherapy standpoint, we really utilize some platforms that are genomic profiling, where we can send the patient's own tumor tissue for analysis to help decide whether the patient is going to really benefit from chemotherapy or not. Again, there's side effects associated with the chemo. So we can avoid it because the patient is not going to derive a benefit. Why expose them to the added side effects of chemotherapy? So we utilize that technology. When it comes to radiation, we have the proton therapy. For those patients who have left-sided lesions that might cause cardiotoxicity, if necessary, we have the ability to provide with the proton therapy so we can minimize any cardiac side effects. So this is all part of the conversation. And Angelina Jolie cannot be ignored in this arena. And after she went public with her story, it's going to be almost 10 years ago now, we really have seen an increase in the women asking for a bilateral mastectomy. Certainly when you have a genetic mutation, that is going to be the recommendation. But when you're not, certainly we know it doesn't really confer a survival advantage. So certainly when I ask patients what is the number one reason when they don't have a mutation, but they request to have a mastectomy, the number one answer is peace of mind. And it's my job to remind them that even after they have a mastectomy, no zero possibility of the cancer coming back. It's still 2 to 5%, but as close as we can get to that zero. And we can do great work. I work with an incredible group of plastic surgeons. This is a lady who had a skin-sparing mastectomy, which is an operation that we can selectively perform in certain patients. We can save the whole skin as well as the nipple-alveolar complex. And we can, obviously, you cannot tell the difference in this patient. You can see the results are really incredible. But it's about, again, patient selection, as some of my other colleagues were talking about. It's not the right operation for every patient, but those who are, it's a great option that we have from the cosmetic and oncologic standpoint. A lot of women now, they don't want any reconstruction. They want to be flat. And this is a movement that has become really popular. It started in New York and has taken, the United States by storm. And if they want to be flat, we certainly can provide that as well. So the flat movement has become very important in the United States, and is definitely a very personal choice, but it's good to be able to provide the patients with what they think is best for them. So needless to say, the breast cancer journey is a road. Certainly the patient is at the center of it, but for us, between family, friends, quality of life issues, we have an incredible team of patient navigators who are oncology nurses who escort the patient throughout the whole journey. Once they finish with surgery, they go to medical oncology, radiation oncology, they're a whole continuum of care. They're a factor and a constant for the patients as an added resource besides their immediate team. In addition to that, we have an incredible team of support, survivorship. Over 3 million survivors in these states just because of the quality of the care that we can provide. And we need to provide for what happens after the completion of the treatment. Is as important as during treatment, from the psychological, exercise, rehabilitation, nutrition, exercise, yoga. So it's all the holistic approach that we have a very strong program for our patients. And certainly this is the model that we have, anything from stress, psychiatry, rehab, nutrition, as I mentioned, and it's all trying to keep them healthy as they go through survivorship as well. And this is all a compilation of all the research, the technology, as well as all the new information that we have. A lot of you've heard from my other colleagues this morning. As we continue to learn more about the biology, we can continue to shape that future. And AI has a role. We think that it's going to have a very important role in imaging, trying to see features that we can identify even before they completely manifest by pattern recognition, as well as from pathology, high-risk conditions that we might be able to identify patterns even before they develop into cancers as part of the utilization of AI. But ladies and gentlemen, despite all these advances, I still have a little black box. And would everyone want to venture what's in my black box? Huh? The future. In my black box, I have the following. Despite all these advances, we still see that there's a higher likelihood of developing, breast cancer in higher mortality in African American women, even though they have a lower likelihood of developing breast cancer. We know that Black women get diagnosed with breast cancer at younger ages. Same applies for Latin women. We know that both Latin women and African American women tend to be diagnosed at later stages of disease. And I already mentioned how the breast cancer is the #1 cause of cancer death in Hispanic women. So it is the leading cause of death in Latino women. And we know that there's a very complex interaction between socioeconomic, social factors that impact these outcomes. However, we know that there's also biology behind it. Both African American women as well as Hispanic women tend to be diagnosed with the more aggressive, the triple negative type. So it's very important to continue to understand these biologic subtleties as we continue to understand this continuum from prevention to survival as we continue to care for our patients. And we know that every single time a patient walks through the doors at Miami Cancer Institute, they bring a story. Everybody's different. Not only do I have to focus on the type of breast cancer that they have, I will be able to help them with our team, but also their fears, their concerns, they might be coming from far away. So everybody has their own issues, but it's all about the centered approach care that we provide. And I think that's one of the main differentiators between us. Patients are not numbers. Patients are treated as people and not as their disease. And that's extremely important to us. As actually Dr. Zinner, our CEO, from the beginning, he was always about high tech, high touch. And that's something that we take very, very seriously. We still have some challenges ahead. Certainly, we're still recovering tremendously from the pandemic. I cannot tell you how many women with late stages of disease have been coming to our clinic. Already spread to the lymph nodes. I had a lady, 42 years old, who I just saw 2 weeks ago, already stage 4 breast cancer. Despite all the education and awareness, we still see this. And I think a lot has to do with still the COVID-19 sequela of people really not taking care of themselves and not following the screening guidelines. We've gone from what's maximally tolerable from the Holsteinian era to what we need to do to cure patients, from what's anatomical to that's biologically appropriate as we continue to learn the subtleties of the biology of different types of cancer, to additional medicine, to evidence-based. Clinical trials are key to keep learning about the different types of subtleties in breast cancer and continue to move the pendulum forward. And from science to treatment planning, because we have to continue to learn. I've been doing this for 30 years, and to see women in the hospital not knowing if they were going to have a mastectomy or lumpectomy because the core biopsies didn't exist and they had to go to operating room just for diagnosis, to see what we can do now that we spend hours talking to our patients about their options. It's really great to see the evolution as we're trying to maintain quality of life. Certainly, we need to keep changing dogma and challenging the dogma as we continue to decrease that collateral damage. I'm excited that we're going to have a new house across the street. We had the groundbreaking for the Women's Cancer Center on September 18th, and we're very excited that we'll be able to hone in and really focus on women's care in that building, which is going to be a beautiful building. But again, what's most important is going to happen within that building. So all under one roof, it takes a village. As I said earlier, I'm very privileged to work with an incredible group of colleagues. These are my fellow breast surgeons, certainly medical oncologists, all who only do breast, radiation oncology experts, my breast imaging interventionalists, the list goes on and on. We have also a benign breast clinic, as well as breast cancer prevention clinic, where we want to keep patients in the pre-viral stage before they develop their breast cancer. My colleagues in plastic surgery, rehabilitation, as well as the genetics that really has become a foundation for what we do in cancer. So ultimately, it's this continued marriage between technology and human touch that has taken us where we are today. And I'd like to thank you for your attention. And again, thank you for invitation for having me this afternoon, and enjoy the rest of the meeting. Thank you all.
You want to take a seat? At this time point, I'll invite the speakers to come back to the stage so we can have
Nice to see you.
a Q&A session. So I would thank all the speakers for a number of exceptional talks about what we are doing. And as Dr. Mendez said, it takes a village. I hope you got the message that luckily at Miami Cancer Institute, we are very fortunate to have had the investment that was made by Baptist Health to really create a world-class facility here, whether we have showcased that hopefully to you in terms of technology, genomics, multidisciplinary management, tumor boards, and as was outlined, we actually have tumor boards for all of our cancer patients. We at least meet once a week where multidisciplinary team of surgeons, medical oncologists, radiation oncologists, and a number of support services group are there to discuss every care. Because a lot of times we have evidence-based care for our patients, sometimes we don't. And as Dr. Meda alluded to some examples, sometimes these discussions actually generate ideas that then lead to clinical trials that we run with collaborations all over the world and create evidence to treat those patients. So if anyone has a question, I would request you to find a microphone. And if not, I'm going to start with a few myself. So Manesh, I know you are, as you proclaimed, we are lucky that we have all the radiation modalities under one roof. So sometimes we have more than one. So if someone comes to you, what are some of the questions you look at, to pick the right modality? That's number one. And second, obviously, a lot of patients who come to see us from international or away from distance, we have capabilities of doing hypofractionated radiation. Can you talk to us a little bit about that, so that we can inform our friends when they give us the care of their patients?
That's a great question, Manmeet. So in radiation therapy, we focus on two things. The first is a therapeutic window. How can we maximize our ability to control the tumor and minimize harm to the patient by treating the least amount of normal tissue? And we have mathematical metrics, and Dr. Mendez talked to you about AI. These metrics are now AI powered. We can actually do this without the patient. We can actually do this all based on a CT scan or an MRI scan of the patient. We can predict the risk of toxicity. We can predict the risk of local control. So using these metrics, we can actually triage different therapies in terms of what's going to be the best for the patient. But layered on top of that is the second element that Manmeet brought up, and that is time. Radiotherapy is a commitment of time. Cancer care is a commitment of time on the part of the patient. And time is money, time is effort. So we also want to introduce time savings. And so that's the second component that goes in. Can we shorten the courses of treatment? We heard about what COVID did to us in terms of negative issues. One of the things COVID did to us was force us to rethink. And one of the things we have done is a series of clinical trials that carry the acronym SMART. And one of them is called SMART 1. What that means is we do all the radiation in one treatment for certain patients. So there are actually a number of clinical trials that we've run. And for a number of patients, maybe just one treatment, sometimes it's 3, sometimes it's 5, but ultra short courses of radiotherapy can be quite effective. So that's another development that has come out that we're pursuing. So thank you.
Thank you, Banesh. Next, moving on to Dr. Manohar, and you talked about obviously prostate cancer, a number of modalities, nanoknife, high frequency ultrasound, or prostatectomy, again using robotics and things like that. So when a patient comes to you, what are some of the questions they may be asking, or how do you pick one modality versus the other?
Thank you. That's a very important question. Most important thing is that the dialogue between the patient and the physician. And most of us will have some bias. If you're a surgeon, you're biased for surgery and you have radiation oncology bias. But it's nicer to become unbiased and give a full explanation to the patients and give them all the resources to look at it. And unlike other cancers, prostate cancer, those patients are suitable for more than one treatment option. Somebody is maybe very scared of surgery and they might go for the radiation treatment. But there are certain conditions where you offer one over another. But important thing is that be open with the patient and honest and offer them all the treatment possibilities and then make a discussion together. And I normally have more than one discussion with the patient and also make them go see the radiation oncologist, or they've seen them and coming back to us and make a decision. But there are certain points like which will make it happen. For example, if the patient is younger, they're going to live for many years to come, some of them might not have an aggressive disease. They might be more suitable for active surveillance. They can have a good quality of life for next 10 years. And then you make a decision, like if needed, at the time they can, progressors can have surgery or radiation. Similarly, the radiation oncologists have a discussion with them. Some of their family members might have a bad experience with radiation. They may not want it, but it's our job to tell them, hey, this is not due to the radiation, due to the individual patient. So at the end of the day, to make it simple, it's a clear, unbiased discussion with the patient, and the physician makes the difference.
Thank you so much. Next question for Dr. Jane Mendez. Jane, again, great talk, highlighting all the aspects of breast cancer. One of the things I wanted, if you would share with the audience, obviously, as you had outlined very eloquently in your talk, we've gone from an era, and we saw that with other surgeries too, from larger incisions to smaller incisions, quicker recovery times, preservation. Can you talk about the concept of neoadjuvant chemotherapy and surgery, especially in light with some of the data that is coming up with immunotherapy for triple-negative breast cancer?
Thank you. So actually, just before I came here this afternoon, I had one such patient. She came, 61 years old, triple-negative breast cancer. She's had symptoms since August, and she hasn't done anything. Clinically, the mass is already inverting her nipple. I felt nodes in the clinical examination. So right off the bat, I told her that she would most likely require neoadjuvant chemotherapy. So we can not only try to shrink the tumor to improve her surgical options, but also to try to downstage the lymph node. And I clearly stated, if I were to offer an operation right now, I would need to perform a mastectomy, plus I would have to remove all her lymph nodes. That alone would increase the likelihood of lymphedema from 5% to 20%. And she's a young lady. I don't want her to have 20% likelihood of lymphedema in her future, because that can really incapacitate her quality of life. So I immediately called one of our medical oncologists. They're going to see her. I also got all the appropriate studies, but that is part of that personalized care that we need to provide, and certainly she would benefit. And when we did chemo upfront in this setting, we expect at least 50% downstaging of that lymph node. So at least a half of the patients I'll be able to avoid having to complete the axillary dissection and save her the 20% likelihood of lymphedema. So is that the personalized approach that we need to have with every single patient? The other new patient, other story, 37, triple positive, just today. So also 37, she's had symptoms since May. She hadn't done anything. She was attributing to her menstrual cycle. So being triple positive, and also felt a node clinically. So she's going to need to also have HER2 targeted treatment, continue the therapy, immunotherapy for about a year, but it's just what we do every day.
Thank you so much. I think what Dr. Mendez shared really highlights the need for reaching out if you have doubt to us early, because we are obviously very happy to take care of patients if you think we can serve them. But I think reaching out earlier to us, I think would help the patients, because sometimes that can modulate how you will plan for the patient. And I think a lot of this is collaboration, us working with you, just like we do with a number of patients around the country who come to seek care. I thought I saw a raised hand. Please go ahead. Can we have a microphone there? Okay.
All right. I have it. This question is for Dr. Mendez. Thank you for your excellent talk. You had mentioned the innovations, especially with AI. Do you offer AI reading for mammographies, like as a second or third read? And the second question is, do you offer lympho procedure for axillary dissections?
The first question pertaining to AI is already integrated in our technology for mammogram screening. So our breast imagers are using it already, and already exploring other more advanced platforms that we might be able to benefit from. So it's already part of their readings. When it comes to lympha, pertaining to trying to avoid lymphedema, we are not currently performing lympha procedures here. I know it's been a research modality. It really hasn't been proven, as well as sentinel, as node transferring that can be used to try to avoid lymphedema. We are not currently offering here at Miami Cancer Institute.
Thank you. There's another question behind you. Yeah.
The proton treatment could be the new gold standard in breast cancer.
Well, I didn't hear the question. No, no.
The proton treatment
Uh-huh.
could be the new gold standard in breast cancer.
No, not, we only consider it for left-sided breast cancers, where we know that the cardiotoxicity might be an issue. Over here, since Dr. Mehta and his team have all the toys in the world for radiation, what we do is they will do all the planning, taking all the techniques into consideration, and if it is a proton that provides the best plan for the patient, then they will proceed with proton therapy. But it will not be the standard for the time being. Dr. Mehta, you can add, as he's the expert.
There are 3 groups of women where we think proton therapy will potentially excel. One is women who need radiation to the internal memory lymph nodes, which puts the cardiac vasculature at high risk for getting radiation dose. Proton therapy excels at lowering the dose to the cardiac structures. The second is very young women, where even if we're treating a very small volume of the breast, the fact that these women are going to survive for a very long time and have considerable longevity ahead of them, the risk of a secondary malignancy, even from low doses of scatter radiation to the contralateral breast, can be diminished with proton therapy. And the third group of patients are women with unusual anatomy, where the standard photon radiation makes it very difficult to get around the curvature or the flatness of the chest to avoid radiation to the lungs or the heart. So these are the 3 groups that benefit from proton therapy.
And also, most of our patients are treated in the prone position, also with the idea to try to minimize any side effects to the underlying structures. So most of our patients are trained prone.
That's correct.
I see another hand.
My question is to Dr. Manoharan about the prostatic artery embolization. What's the role of that in the prostate cancer? And as a cardiology, I'm very oncology naive. And my second question to all 3 of you is, how big of a role is genetics playing in the cancer? So when you see a patient with the cancer, do you routinely do a genetic testing for particular cancer? If, let's say, if you're seeing a patient with a prostate cancer, breast cancer, we already know, but there is specific gene testing that you do for each cancer patient?
Sure. Thank you for the question. The question is about the role of prostatic arterial embolization. Mostly, it is meant for benign condition to reduce the size of the prostate through the, the catheterization through femoral artery or radial artery. It's a very, very effective treatment. For prostate cancer, it's got 2 roles. For example, I have a very large prostate and I need to do a radical prostatectomy. The way I've done that is that I bring the patient to the interventional radiology, they do the embolization and then bring the patient down and do the procedure immediately, which shrinks the size of the prostate and reduce the bleeding. However, if you do the embolization first and try to do the radical prostatectomy, say a few weeks later, and there'll be a lot of fibrosis and the planes are not well developed, so it's better not to do it that way. So the main role is to reduce the size of the prostate to do the surgery better. I've spoken to the radiation oncologists. They feel that if I use the embolization, it causes ischemia, and in ischemic tissue, the radiation does not work very well. That's what I was told, and that's why we don't use it in the radiation oncology thing. With regards to the genetic testing and the things, right now, we are offering genetic testing to almost every patient at this point of time. However, in prostate cancer, if you have a high-risk prostate cancer, we send them for a genetic testing, particularly BRCA1 and 2. And in the kidney, we do also do it. But the bladder cancer, the role is very limited in the beginning.
So with that, I really want to thank all the speakers. I know we're a few minutes behind time, but the speakers will be around. And I would pass it on back to Dr. Ribas to conclude this session.
Manmeet, do you want to take the genetic testing question as a global strategy?
I mean, I would just add, while Dr. Ribas is coming on stage, that, some of the talks previously also alluded to it. I think we think genomics is really the basis. We are understanding more and more. I did not talk about it today, but there are now drugs which are approved for genetic alterations across all cancers. So just to give you an example, larotrectinib, for example, is a drug that is approved for people with NTRK gene fusions. So no matter what cancer you may have, you can actually get that drug. So just to give you an example, since I'm a brain tumor expert, glioblastoma, 1% of them have it. Now, it would have never been approved in GBM alone, but it got a pan approval. And similarly, a number of drugs are approved, red gene fusion drugs. We've got a approval for pembrolizumab for MSI high tumors, patients who are likely to have these genomic alterations that may respond beautifully to immunotherapy. So I think genomics is increasingly becoming an important part and parcel of how we treat our patients. And that also, I think family history is a big part. And so we have a genetics program where we refer our patients if they have either an alteration, a germline that we think would need a counseling with a dedicated person, and then discuss with them what would be needed in terms of their family screening as well. As we are learning more, I think we are advancing more and more. And one more theme I'll just say in a quick is that, as Dr. Diaz had alluded to, that beautiful case where he salvaged the patient's vagina for radiation, we are also seeing an increasing burden of cancer in young patients. And I think that is going to bring into even more importance this multidisciplinary management or getting your care at more comprehensive cancer programs, because you want not only to take care of these patients well, you expect these patients to beat the disease and live for a long term. So survivorship comes into the picture, as Dr. Mendez had talked about. So there's a lot more we can do for our patients now than we were able to do a couple of decades back. And with technology, I think this will just usher us a new era where we can serve our patients longer and with better quality of life.
Thank you, Dr. Ahluwalia, and thank you for moderating an incredible session. Dr. Manoharan, Dr. Mehta, Dr. Mendez, thank you. A round of applause for our Miami Cancer Institute team. And it's been an incredible day to learn from our multidisciplinary experts and cutting edge treatments. But on behalf of Baptist Health International, I would like to thank you and thank all our physicians and moderators today, even though they weren't here. After I couldn't see them, but I will in person. As we conclude today's program, I also like to express my gratitude to all those who traveled during this busy time of the year. And thank you for participating today. We're incredibly proud of the hard work and dedication of our doctors and staff, whose efforts have positioned Baptist Health as a global leader in healthcare and the premier provider of compassionate, high-quality care in this region. We hope your time has been productive and insightful, and we hope that this is going to foster the relationship to be able to share information and continue to grow. I think you've seen across so far the three divisions the same communication, and I think we are truly different. As a reminder, we're going to be taking a picture outside, so if I can bother you for one quick minute when we go outside, everybody to take a picture. You're invited to join us tomorrow morning for breakfast, 7 a.m. At 8 a.m. before our final session, which will be the Miami Cardiac and Vascular Institute. And so we hope to see you. It's going to be a very informative day, and we're going to have our heart and vascular experts available. So after tomorrow's session, we will tour the Baptist Health Miami Cardiac and Vascular Institute. Shuttles will be available to transport all guests to the institute starting at 10:45. After the tour, the shuttles will return you here for lunch and adjournment of the symposium. Finally, I encourage you to stay for the next hour and continue networking with your colleagues. For those traveling home today or tonight, safe travels. Thank you once again, and enjoy the rest of the evening.